and I'll tell you to say a few words, and then I'll just talk in brief why this workshop is being organized.
That's
and
what
then
I'm about.
No, then I will just talk whatever you don't speak. I will talk that, and
No,
then
what will I say in the welcome? I've already prepared it.
no, you say whatever you want to say.
Okay.
Okay.
Ma'am, if you,
And then
if you want to talk
and then I'll just also.
if you can mute and unmute, mute the mic and camera. Because
So I'll then Dr. Mohanan just wants to speak a two words. So then I will just call him to speak 2 words, and then we'll start.
Okay.
I can't hear you again.
Oh Lord! Now
we can hear you. We can hear you.
Okay.
And we are live. We are live on the webinar platform now.
Okay. We are live means what?
On the platform, the webinar platform.
But we have not yet started, no? How can we be live?
So if we talk or if we put say anything, that will go on the platform now.
No, but you need to edit it later.
Yeah, that we will do. So for the timing, if you can keep your camera and mic off, and then.
Okay, fine.
Good morning, everybody. I welcome you all on behalf of the PCOS Society for the pre-Congress workshop on Does PCOS Affect Your Heart and Cardiovascular System? I now invite our president, Dr. Dhuru Shah, who is the director of Gynec World, the founder president of the PCOS Society of India, and founder trustee of the Women's Empowerment Foundation. She is also the trustee and past president of the Mumbai OBGYN Society, chair of the Special Interest Group on Reproductive Endocrinology and PCOS at Aspire, and international advisor for the Special Interest Group of ASHRAE. She is also the chair of the Indian Special Interest Group for the American Society for Reproductive Medicine. She has been the past president of ISAR, FOXY, and Indian Menopause Society in India. She is also the past director of the Digital Education wing of the International Menopause Society and the past chair of the Indian College of OBGYN. She is the honorary fellow of the Royal College of Obstetrics and Gynecology. She is the first and the only Indian to receive the Pcos Distinguished Merit Award for services towards women's health. I now invite her to welcome you all.
Thank you so much, Madhuri, for this invitation and welcoming the audience on this behalf of the PCOS Society of India. As president of the PCOS Society of India, I have always wanted to understand how we need to take care of our women with PCOS after they have visited us in their, in their whatever complaints they have come up with. Now, the question is that when they come to us, they may have come to us for various indications. They must have come to us for sometimes just acne, cosmetic issues, irregular periods, infertility, whatever. Now, if they've come to us with those problems, we have sorted out their problems. But as gynecologists, I think it's very important for us to make sure that we follow up on these women because we know what are the problems they are associated with as they age. We also know that there's a lot of metabolic syndrome which develops in these young people. Even at the young age of 15 and 16, I've seen metabolic syndrome. And as they age, as menopause sets in, there is always a higher risk of them having a higher metabolic syndrome problem as compared to the non-PCOS women. We also know that when we treat our patients for infertility, and we try and prevent ovarian hyperstimulation, but at the same time, they do get hyperstimulated sometimes. And in the past, we've seen it many, many times. And with this hyperstimulation comes thromboembolism, which can lead to fatal issues in such women and serious cardiac risk. So in short, there are areas in our practice where we see women where we can prevent a problem in future. And that we can prevent only provided we are aware of the problem. If we don't know what we are looking for, we'll never find it. So in short, it's important for us to understand what are the cardiological risks for any event, like say a cerebrovascular event or a cardiovascular event. It's important for us to understand what is the current update on this knowledge, what we need to understand the principles of this problem, how they affect PCOS patients, and how we as gynecologists who are primary care physicians of women need to take care of them so that we can prevent future cardiac morbidity and mortality. Besides that, there is also cerebrovascular accidents which occur. Cerebrovascular accidents can give rise to clots in the brain, subchorionic hemorrhage, etc., etc. And those also can cause problems with cardiac disease and with future morbidity. So there are various clinical situations I can think of. When we operate on a patient who's got a varicose veins, we know that we have to take care and prevent thromboembolism. We think of all the preventive measures because the patient is bedridden for some time, and we need to make sure that she doesn't develop, deep vein thrombosis. So we have various protocols we follow. But in spite of that, there are issues. And in the recent past, I picked up a patient with all the precautions. She developed a hepatic vein thrombosis. So in short, we pick up things earlier, we pick up problems, and we could prevent liver damage in that patient. So idea is to prevent problems, not to really treat them, but manage those problems in a way till we can refer these patients to our expert friends who will then manage them further and prevent issues. And hence, I've been delighted to associate with the Cardiological Society of India, the cardiac experts, Dr. Mohanan and his team, who are going to update us on the principles of this problem, how to manage so that we prevent issues, and how we can then decide when to refer to the cardiologist for expert treatment of our patients. So thank you very much, Dr. Mohanan and team, for joining us. And of course, I must thank Madhuri for convening this whole program and executing it. It's a year when we have gone, the Pcos Society of India has collaborated with various organizations, and we have been able to collaborate with them and learn from them and understand what we need to do further. So thank you very much, and I welcome all the delegates, and we hope that we have a great morning and learn a lot from each other. Thank you so much, Madhuri.
Thank you very much, Dr. Durusha. The PCO Society is extending hands to educate to reduce the epidemic by several scientific endeavors. And the aim of the society is to bring together all specialities. And so we bring today this workshop on cardiovascular system. The goal of this workshop is to review the state of the science on the cardiovascular disease across the lifespan of women with PCOS and identify the knowledge gaps and challenges in the PCOS-related cardiovascular disease and research. I thank Dr. Mohanan, President of the Cardiology Society India, and Dr. Praful Kerkar, who is my friend and classmate for last 40 years, to coordinate with us for this workshop. I would now like to introduce the two chairpersons for this workshop, Dr. Sujata Kar. Can I have the CVs, please? Who is the moderator for the first session on the pathophysiology of cardiovascular disease in men and women. She is the director, Kerr Clinic and Hospital Private Limited, Bhubaneswar, honorary treasurer, ISAR. She is a managing committee member of the PCO Society India. She has several medals and awards to her credit, and she's had many first shown credit in the field of ART in Orissa. She is also a recipient of the Parichay Award for Women's Achiever in Odisha in 2019 from the Honorary Governor of Odisha. She's written several chapters and has several publications both in national and international journals. Next. Our second moderator for the day is Dr. Sushma Bakshi, and she is a clinical head, Oasis Fertility Clinic, Vadodara in Gujarat. She's also director of the Subecha Multispeciality Hospital. She's a patron member of the PCO Society India and also of the FOXY. She's also a member of ESHRE, ISAR, and Indian Menopause Society. She's been awarded the WHO Fellowship Award at the Harvard Medical School, Boston. Her areas of research, interest are research in endocrinology, ultrasound, and infertility. Next. Next. So our first speaker for the day is Dr. Chandrabhan Meena. He is the Senior Professor of Cardiology from SMS Medical College Hospital, Jaipur. And he has to his credit the FACC, the FSCAI, FECS, and FSCAI awards. His area of interest is interventional cardiology, electrophysiology, and clinical research. May we have Dr. Chandrabhan Meena for the first lecture of today's workshop.
Good morning, everybody. First of all, I would like to thank Dr. P.P. Mohanan and Dr. Patil and organizers of the PCO Society for giving me the opportunity on discussing pathophysiology of CAD in men and women. So I have divided my talk into two classes. One first half is basically discussing the pathophysiology of the CAD, and later on I'll be discussing what are the gender differences as far as the CAD is concerned. So coronary artery disease is divided mainly into two classic categories. So one is the chronic stable heart disease, so where patients usually have stable angina and they are stable, which may be having variant angina or silent myocardial ischemia, which is detected on exercise testing or other invasive modalities. While the other spectrum of the presentation of CAD is acute coronary syndrome, which includes unstable angina, non-ST elevation, MIST, segment myocardial infarction, which can be sometimes fatal and can lead to sudden heart death. We all know that we have two major coronary arteries. One is the left and other is the right coronary arteries. And the left coronary artery is divided into two branches in the anterior descending and left circumflex, which mainly supplies the blood to the heart and which is the main supplier of the oxygenation. And since time tested, we have come to understand that atherosclerosis is the major cause of CSD in adult population. And atherosclerotic plaque disruption is the most common cause of acute myocardial infarction. More than 90% of the patients with CSD has evidence of coronary atherosclerosis. So this is one of the important pathologic mechanism for atherosclerosis and CAD. And most patients with CSD have one or more stenotic lesions, which is more than 70% by luminal stenosis, and therefore it leads to symptoms of angina and other dyspnea. And the plaque formation can affect one of all major epicardial arteries. So we can have one major artery or multiple arteries, and we can have multiple lesions if we do the angiogram. So coming to the pathophysiology of the chronic CAD, previously it was considered that it is a cholesterol steroid disease, but now we have come to understand that it is a complex interaction of risk factors, including the cell and arterial wall and blood and molecular passage. When the endothelium counters certain risk factors like dyslipidemia, hypertension, hyperglycemia, pro-inflammatory cytokines, there is increased expression of adhesion molecules that promotes sticking the leukocytes to the surface of the endothelium. And the transmigration of these leukocytes then takes place, which are later taken up by the monoclonal phagocytes and T lymphocytes, and later on they release various cytokines, and this leads to formation of the atherosclerotic plaque. These cells communicate with the smooth muscle cells, endothelial cells, which leads to the proliferation of the smooth muscle cells and development of plaque and progression of the atherosclerotic lesion. Major exchanges takes place with the help of prostanoids and leukotrienes, and the vascular muscle tone is regulated by the autocoils like histamine. So interaction of all these molecules is important as far as the pathophysiologic mechanism of chronic and acute coronary syndromes are concerned. Once the smooth cells migrate from tunica to media, there is interplay with the endothelium, and matrix metalloproteins are liberated from the cells, which leads to the hemodynamic inflammatory and autoimmune signals. And the imbalance with the cells and matrix metalloproteins leads to activation, proliferation, migration, and cell death, as well as new muscle formation, which leads to various pathological changes. And certain constituents of extramedullary proteins also are oxidated by a non-enzymatic diagostion with the presence of sugars. So all patients who are diabetic, where increased level of sugar in the blood, there is non-enzymatic conjugation and leads to increased glycation of these products. Ultimately, there is calcification, as is seen in the bone formation. So some plaques may be calcified. And finally, there is cell death with the use of because of apoptosis, and this leads to release of the lipids in the cell matrix. It leads to the formation of necrotic core within the atherosclerotic plaque, and this is the main pathologic lesion for the rupture of the plaque. So this diagram shows the various stages of the plaque formation or the formation of the atherosclerosis, which is the main pathologic mechanism of the CAD in men and women. Initially, in the presence of risk factors, the leukocytes adhere to the cells, and this is engulfed by the monocytes, and then the lipids are oxidized. There is formation of fatty streaks. Later on, the plaque formation takes place, and there is release of addition of platelets, which leads to liberation of certain cytokines, and thereafter proliferation of the smooth muscle cells, and there is increased plaque burden, which leads to stenosis of the lumen, the coronary lumen, and leads to production of the symptom. So till this stage, the patient is asymptomatic, but they have underlying pathologic mechanism, and they are prone to have acute coronary syndrome. But once the plaque gets serious stenotic, they become symptomatic. And when this plaque rupture, because of the various mechanisms like acute stress or the other risk factors, there is acute occlusion because of the thrombosis, and this leads to the acute coronary syndrome, which we know as acute myocardial infarction. So arterial remodeling is clinically critical component of arteriogenesis, and we can have two types of lesion. One is the stenotic lesion, which I have described. There is inward progression of the plaque, and there is outward progression of plaque. So this is known as positive remodeling, and this is known as negative remodeling. So negative remodeling leads to stenotic signs and symptoms, which have different treatment modalities like PTCA, stenting, or CABG. While patients with positive remodeling do not have symptoms, but they can have rupture, and they may be asymptomatic till late presentation. As I said, stenotic regions have a small lipid core. They are more fibrotic and calcific, so they are stable. The main problem with this is they produce the symptoms of ischemia and angina, but they do not produce any acute coronary events. While the non-stenotic lesions have positive remodeling, they also have fibrous cap and less lipid plaque. So, but they are prone to rupture, and they can have acute penetration. Most important are the non-stenotic plaque, which may cause no symptoms, but once they are produced, acute shear stress can lead to acute rupture, and they can present as unstable angina, so that the patient is unaware of their atherosclerotic disease, and they can have acute coronary syndrome. These lesions usually coexist, and they may have, any patient can have multiple lesions, like a stenotic and non-stenotic lesion, and they may have non-stenotic plaque. So out of these, non-stenotic plaque are most important because they can have acute presentation, even sudden death. As far as the pathophysiology of acute coronary syndrome is concerned, there is physical disruption of atherosclerotic plaque, which accounts for almost all acute myocardial syndromes. And through and through rupture of the plaque leads to liberation of the substances in the vascular lumen, and it leads to generation of thrombus and acute occlusion of the valve. This leads to intraplaque hemorrhage, erosion of calcified nodules, and all of them ultimately leads to acute coronary syndrome. Rupture of fibrous cap is basically seen in 2/3 of the patients who present with fatal coronary thrombosis. So this is the main mechanism of acute coronary syndromes. And superficial erosion is seen in almost 20% of the cases. This is one of the main pathogenic mechanisms in diabetic and women, where rupture is not common, but superficial erosion is common, and they can lead to unstable or acute coronary syndrome. Sometimes there may be erosion of calcium nodule, which can also lead to development of acute thrombosis. Consequent to the local plaque rupture or erosion, there is generation of thrombin, which may stimulate smooth muscle sand, and that leads to rapid expansion of the plaque. So if we do angiogram 6 months later, the angiogram may not be significant stenosis, but after 6 months, the patient may have significant stenosis. Sometimes intraplaque hemorrhage can cause sudden lesion expansion and acute coronary syndrome. So this diagram illustrates all these findings. There may be acute rupture of the plaque. So there is liberation of the chemical substance within the lumen. This leads to thrombin formation and generation, development of large thrombus and acute occlusion of the thrombus of the coronaries, leading to acute coronary syndrome. There may be superficial erosion, or there may be erosion of the calcium nodule. Both of these leads to the rapid or the subacute thrombosis, while there may be an intraplaque rupture, which can lead to progression of the plaque, but there may not be acute thrombosis. There are various determinants of generation of thrombosis or acute penetration, which may be in the fluid phase or maybe in solid state. So these are plasminogen activator inhibitor, fibrinogen, circulating tissue factors, thrombomodulin, urokinase like plasminogen activator, tissue plasminogen activator, and the smooth muscle cells. So interplay of all these elements leads to ultimately formation of plaque or formation or the presentation of acute coronary syndrome. As far as the category is concerned, the plaques can be divided into two, like a stable or unstable plaque. So the stable plaques are usually fixed. They are thick or they may be calcified, so they do not produce any acute catastrophic event, but they have chronic symptoms. While the unstable plaques are vulnerable and they can present with acute coronary syndrome. And the rupture depends on the size of the lipid core and thickness of the fibrous cap. If the cap is thin, there may be acute rupture, and this leads to acute coronary syndrome. Apart from this, presence of inflammation, plaque degradation, lack of smooth cells, or all of these can lead to unstable plaque and formation. So this is the various stages of the CAD. Like the patient, in the young age, you have the normal coronary artery with the normal lumen and smooth muscle, smooth endothelium, and there is asymptomatic atherosclerotic plaque. Once the plaque is more than 70% of the luminal diameter stenosis, they lead to stable coronary syndrome. And once there is a rupture of the plaque or erosion, they may present an unstable angina, non-ST elevation MI, or if there is complete confusion of the lumen with the thrombus, they can have ST myocardial infarction. So these are the various pathogenetic stages of the coronary artery disease, from stable to unstable coronary syndrome. And these are the main presentation of the CAD. Now coming to the gender differences in coronary artery disease. So what are the various gender differences? The cardiovascular disease develops 7 to 10 years later in women compared to the men. But this is one of the major cause of death in women of 65 years or more. And the risk of heart disease is often underestimated due to the misconception that the females are protected against the cardiovascular disease. This is one of the fallacies, especially especially in our country also, that we should always be suspicious of acute coronary syndrome or chronic CAD in patients, in females who have some non-specific symptom. Recent data from the NHS survey has also said that for the past 2 decades, the prevalence of myocardial infarction has increased in women between 35 to 50 years age, while it is declining in the men. And in the European Heart Survey also, they said that the functional testing of ischemia and diagnostic angiogram and intervention procedures are carried out less often in female compared to the men. And this had led to the less aggressive treatment strategy and lower representation of the women in clinical trial. Furthermore, it should be highlighted that self-awareness in these women and identification of their cardiovascular risk factor needs more attention so that we can have better preventive strategy as far as the cardiovascular events are concerned. So the role of menopause as far as the CAD in women is concerned. Before menopause, event rate in the CAD is low in women, and patients who have early menopause, that is less than 40 years, they have 2 years less life expectancy. So it has important bearing on the life expectancy. Data from Framingham study suggests that it may be just a coincidence of the age of the patient rather than the direct event. But women's ischemia, that is the WISE study, has shown that there is 7-fold increase in the coronary artery risk with the menopause compared to the pre-menopause event. And as we all know, estrogen has very protective effect because of the various mechanisms. And once the menopause arrives, there is change in the the hormonal imbalance, which leads to atherosclerosis and intimal medial thickness measurements. Apart from this, there is derangement in the flow-mediated vascular activity with the menopause. So all these changes lead to development of atherosclerosis. Menopause transition is associated with worsening CAD risk profile. So women with menopausal age have clinically manifest CAD. They're older and their incidence is higher compared to the risk factors are higher in these patients. And at a younger age, smoking is more deleterious in women compared to the men. And this is the important consideration. The younger females who are smoking have more risk of CAD compared to the men. And smoking increases the risk of acute first myocardial infarction more in women than men. So it is one of the major risk factors as far as the CAD is concerned in female. And in young pre-menopausal women, smoking causes downregulation of estrogen receptors. So this is also one of the important risk factors for the development of CAD. Body weight may increase with first year after the menopause, and the central obesity may increase visceral fat. So there is change in the fat distribution with the menopause, and there are other components, metabolic syndrome, which may creep in. So all of these factors leads to obesity, and there is parallel increase in the prevalence of type 2 diabetes. And women with diabetes are greater risk of CAD compared to the men. A meta-analysis of 37 prospective cohort studies has shown the risk of fatal CAD is 50% higher in women compared to men who are diabetic. And the reason for this higher mortality is multifactorial, which may be related to the high risk factor burden, involvement of pre-inflammatory factors, small vessel size, and coronary arteries, and less aggressive treatment strategy in women. So diabetic females are more prone to have CADs, and they are less likely to get treatment. So they have to be taken care of once they have the clinical signs and symptoms suggestive of CAD. As far as the blood pressure is concerned, systolic blood pressure rises more steeply once the menopause sets in. And this is because of decline in estrogen level in the menopause transition. There is an upregulation of the renal angiotensin system, and there is change in the salt sensitivity and sympathetic activity. So at older age, that is more than 75 years, isolated systolic hypertension is 14% higher in women compared to the men. And the left ventricular hypertrophy is also one. If the blood pressure is just borderline, that is around 140/90, there is a significant endothelial dysfunction. And the patients with hypertension, the female patients with hypertension, they usually have symptoms of pain, palpitation, headaches, and even sensation of hot flashes, which may be attributed to the menopause, but actually they are having another hypertension. And once we treat this elevated blood pressure, the symptoms go away. So we should be very careful in all the post-menopausal women as far as the diagnosis of hypertension and management is concerned, because this is again one of the important risk factors for the CAD in women is concerned. Hypercholesteremia is also one of the important risk factors, and at a younger age, this is associated with increased incidence of CAD. During menopause, total cholesterol and low density cholesterol, that is LDL, rises around 10 and 14% respectively. And this increase in 4 to 8% in the lipoprotein A levels also, which is also one of the important marker for the atherosclerosis. And it may be therefore important to reevaluate the lipid profile after menopause when there is borderline menopause value, pre-menopause values. And after 65 years, LDL is compared with the men, so it is same risk factor as for men. The SGL level is slightly higher in women compared to men, but this does not give total protection as far as the CAD is concerned. There are some special female-specific risk factors like hormonal dysfunction, which is commonly seen in premenstrual and postmenstrual women, and PCOS is one of the important cause of this. So it occurs around 8 to 10% of women, and it is an important cause of infertility. And women with this syndrome are likely to have increased chances of metabolic syndrome and type 2 diabetes, which are the two major risk factors for CAD. So patients with PCOS and metabolic syndrome, they are hypertensive disease in pregnancy, they are associated with increased incidence of CAD, especially women with eclampsia and preeclampsia, and patients with proteinuria after 20 years of age. The CAD incidence is twice high compared to the patients without preeclampsia. So women with placental syndrome or poor fetal growth also associated with increased CAD. So all these patients who have these risk factors, including PCOS, placental syndrome, or eclampsia, preeclampsia, should be carefully evaluated and follow up for any evidence of any CAD. So what is the sex-linked inheritance? Estrogen is said to stimulate phagocytosis, and that's why it acts as a protective mechanism because it gives greater resistance to infection from infancy to old age, and that's why it is said that the sex chromosome is the protective for the females. It may be relevant as a gender gap with the direct evidence with C-reactive proteins, fibrinogen levels are there. And if you look at the base trials, that familial hypercholesterolemia is affected about 10 years later. The patients, female patients with familial hypercholesterolemia are usually 10 years older, so they are somewhat protected compared to the men. And fewer older men, they have less allele of ApoE4. That is again one of the risk markers of CAD. And it has a significant protective role in the females. It produces the HDL cholesterol, increased HDL, and that is how the females are protected with the CADs at a somewhat level before pre-menopause. So what is the role of dihydroepiandrosterone? This is also one of the mechanisms of androgenic hormones, and it is said, and various data has showed that the high DHE levels in women are associated with increased risk of CAD, and the low risk DHES in men is associated with CAD. In men, weight loss and insulin reduction leads to reduction in the DHE, while in female there is no effect of weight loss or a reduction of the CAD. So there is no protective benefit of control of diabetes and exercise in female, while the male have some protective effect of these effects as far as the dehydro and level of DHE is concerned. So what is the effect of the parity? And it is associated with increased CAD risk. This is one of the data which is increased around more than 1 lakh death certificates in England and Wales, and they found a significant increase in death from cardiovascular disease in multiparous women compared to nulliparous women. There may be some confounding. It may be associated with lower social class and less education, but parity is associated with increased fertility. So there are some risk factors which can be there in these patients. There is indirect association of the weight gain and central obesity, decrease in HDL cholesterol, increase in insulin levels, or repeated hormone changes. Apart from that, stress, anxiety, and habits of parenthood, all these can lead to increased chances of CAD in multiparous women compared to the nulliparous women. Metabolic syndrome, as we all know, is associated with increased incidence of CAD, and there is twice as high incidence of metabolic syndrome in women and men. So there is twofold female to male sex ratio in patients who have metabolic syndrome, and they are twice more prone to develop CAD compared to the men. Low HDL and high triglyceride levels associated with metabolic syndrome is again one of the important risk factors for the CAD in these patients. And prevalence of a small and dense LDL is more in female, and they have larger and less atherogenic LDL particles compared to men. So there is more incidence of atherosclerosis in these patients. Obesity is also associated with increased risk factors like cigarette smoking, alcohol intake, or hypertension. And male pattern obesity is genetically determined. So if there is a change in the pattern of the weight in the female, especially which can be especially caused by change in the hormone after the menopause, there may be change in the fat distribution, and that can lead to increased incidence of CAD in this patient. There is some evidence that serum hormone binding globulin can affect the development of CAD in women, and the estimation of this can be indirect marker for the atherogenicity in these patients. Level of cortisol and the cells difference in the fat is the main explanation why the females after the menopause are more prone to develop CAD compared to the men. So this is the graph which shows the difference in the mortality in men and women. If you see the undifferentiated mortality, the mortality of the CAD is much higher in women than men. So we should be very aware, and we should be very careful in diagnosing these patients and managing these patients. And the myth like the female patients are protected of the CAD should be carefully taken up. So in conclusion, I would like to say that cardiovascular disease is a major cause of death in women, and it is under-recognized and under-treated. And this is the main important point that should be highlighted. The role of sex behaviors, response to stress and inherited disease factors, especially hormone exposure, particularly in the utero, can play a role apart from the environment. And plasma estrogen levels do not explain the CAD risk in either sex. So genes that may affect the environment or common heritable risk factors from heart disease are working in both men and women, but they are more like effect of sex hormone. Sex chromosomes can be highlighted in female. Male pattern obesity is not caused by high testosterone level, but in men, the postmenopausal men, the stress hormone androgen interaction may be an important, and that may lead to change in the obesity and the metabolic syndrome. But important to highlight is that greater awareness of differences in presentation of angina, ACS between men and women, and the gender-based interpretation of the diagnostic test is mandatory for all healthcare professionals to improve therapeutic strategies and outcome of women. And this has to be highlighted again, so that the females are treated and diagnosed in time and treated betterly to reduce mortality. The guidelines should be more focused on sex-related differences when it is appropriate. And furthermore, as I highlighted earlier also, that women themselves need to be more aware of their own risk factors. So they should be having the risk assessment time to time. And if they have high risk factors or clinical signs of CAD, they should be properly managed, adequately treated, so that we can reduce the mortality and morbidity, especially acute coronary syndrome like myocardial infarction and sudden death. Thank you very much, and for patient listening. And we can have any question answer we can have later on discussion.
Can we have the CD of the next?
Yeah, thank you very much, Professor. I think we'll have the questions at the end. So let me invite the next speaker, Dr. K. Venugopal, who's going to speak on epidemiology and pathophysiology of cerebrovascular disease. He is a professor and head in the Department of Cardiology in the Medical College of Tiruvalla. He is associated with many societies like fellow of the Cardiological Society of India, Indian College of Cardiology, American and European College of Cardiologies, and he's been the past president of Cardiological Society of India. And his area of interest, as expected, is preventive cardiology. Dr. K. Venugopal, I request you to start your lecture.
Good morning. Before I start my talk, let me thank Dr. P.P. Mohan, the President of the Cardiological Society of India and the PCOS Society for having given me this chance to talk to you on an epidemiology and pathophysiology of cerebrovascular disease. Even though I'm not a neurologist, as I've been asked by Dr. Mohan to do this, I'm very happy to do this particular talk. Strokes account for about 10% of all-cause mortality. If you look at the mortality, coronary heart disease, cancer, and stroke account for more than 1/3 of the leading causes of death. And stroke happens to be the most important cause of severe morbidity. The cerebrovascular disease can be basically divided into ischemic stroke, hemorrhagic stroke, and cerebrovascular anomalies like intracranial aneurysms and arteriovenous malformations. If you look at the incidence and mortality of ischemic versus hemorrhagic stroke, majority of the strokes happen to be ischemic strokes with about 88%, and hemorrhagic strokes only 12%. But if you look at the mortality, it is quite different. Hemorrhagic stroke has a mortality of 36 to 37%, and ischemic stroke or thrombotic stroke has a mortality of only 8 to 12%. If you look at the stroke epidemiology in India, the estimated adjusted prevalence rate of stroke in the rural population is 84 to 262 per lakh population and 334 to 424 per lakh in the urban areas. The incidence rate is about 119 to 145 per 100,000 patients or 1 lakh patients based on the recent population-based studies. Which are the areas in India which have the strokes are most common? West Bengal, Orissa, and the Northeast are the states in India which are the maximum number of strokes. And if you look at the stroke rate in India, incidence of stroke rate in India compared to the West, we have 145 to 154 per lakh individuals a year, whereas USA has only 107, Australia has 99, and Europe has only 61 to 111. 10% of strokes are fatal. 35% of patients will die within the first year, and 30% will experience a new and often more serious stroke in the next 5 years. 30% of survivors become handicapped or develop vascular dementia. And this is one of the reasons why we say that stroke is the most important cause of morbidity in the human being. After a stroke, there is a 2 to 3 times risk for a myocardial infarction because there is a same atherosclerotic pathology that happens in the different vascular beds. In 10% of patients with myocardial infarction, stroke will occur within the next 5 years. Every 3 minutes, somebody dies of a stroke. Stroke increases with age. And what is very worrying for us in the Indian population is that 12% of strokes occur in the population less than 40 years. This is a data published by Shah and Mathur in 2006. For each decade after 55, the risk of stroke doubles. And 72% of all strokes occur in people over the age of 65. The main risk factors of stroke are hypertension, obesity, hyperglycemia, hyperlipidemia, and renal dysfunction. And also 47% could be attributed to behavioral risk factors like smoking, sedentary lifestyle, and unhealthy diet. Globally, it has been estimated that 30% of the risk of stroke was attributable to air pollution. The non-modifiable risk factors, as we know, as for cerebral cardiovascular disease, the non-modifiable risk factors are age, gender, and a family history of stroke and previous history of stroke or myocardial infarction. The major modifiable risk factors are hypertension, which is the most potent risk factor, diabetes, dyslipidemia, smoking, and the risk of embolic episodes like atrial fibrillation. Obesity, high fat and sodium diet, insulin resistance, decreased physical activity, increased alcohol consumption, previous heart disease, patent foramen ovale, which causes paradoxical embolism, connective tissue disorders, migraine, hypothyroidism, sleep apnea, and drug use or other miscellaneous causes. What is interesting for the PCOS group is that obesity and insulin resistance, which are part and parcel of PCOS, are considered to be major risk factors for stroke. The causes of ischemic stroke can be basically intracranial or carotid atherosclerosis or due to embolism. 30% of strokes remain unexplained despite extensive evaluation. What are the most common cardiac causes of stroke? Rheumatic heart disease, especially mitral stenosis, non-rheumatic atrial fibrillation, myocardial infarction, prosthetic heart valves, and ischemic cardiomyopathy are the most common cardiac causes of embolic stroke. There have been certain changes in the trends in ischemic stroke subtypes between 1993 and 2015. A cardioembolism was noted in the white people, but this is basically because of more people living to older age with development of atrial fibrillation, large artery atherosclerosis in Asian population, and decrease in small artery occlusion in the white population. Each year, 55,000 females more than males have a stroke, and females have a high lifetime risk of stroke than males. But in the younger females, younger and middle-aged females, the age-specific incidence rates are substantially lower. But as the age increases, the differences narrow. And the older age group, actually females may be equal or having higher stroke rate than in males. Diabetes increases the ischemic stroke risk in all ages, but this risk is more prominent before 65 years of age. Atrial fibrillation is often asymptomatic and frequently undetected, and therefore the stroke risk attributed to atrial fibrillation could be substantially underestimated. Survivors of lacuna stroke with high burden will benefit with intensive blood pressure control. LDL levels are also associated directly with ischemic stroke risk and inversely with hemorrhagic stroke risk. When you come to pregnancy, pregnancy-related stroke was 30 per 1 lakh pregnancies, 18.3 for antenatal and perinatal, and 14.7 for postpartum stroke. Hypertensive disorders during pregnancy, including gestational hypertension, preeclampsia, or eclampsia, was associated with a greater risk of ischemic stroke. Late menopausal gestational hypertension was associated with a greater risk of hemorrhagic stroke. Oophorectomy, hypertensive disorder, preterm birth, and stillbirth were associated with a greater risk of any kind of stroke. Females who experience menopause before 45 years and increase risk of stroke. Use of estrogens and progestins as well as estrogen alone increases stroke risk in postmenopausal women. If you come to PCOS, the stroke risk in PCOS there's some slightly conflicting data, an increase in stroke risk with PCOS, but there is no increase in mortality compared to other populations. Physical inactivity, use of tobacco, obstructive sleep apnea, and chronic kidney disease are also well-known causes of stroke. Cardioembolic stroke, as far as the cardiologist is concerned, the high-risk conditions that we think of are atrial fibrillation, left atrial thrombus, left atrial myxoma, mitral stenosis, mechanical heart valves, infective endocarditis, and myocardial infarction, left ventricular thrombus. There are miscellaneous low or uncertain risk conditions in cardiology, which may also result in stroke. What is transient ischemic attack? Transient ischemic attack is an episode of stroke symptoms that last briefly. The duration of a transient ischemic attack is less than 24 hours. It may arise from emboli to the brain or from in situ thrombosis. Amaurosis fugax is a well-known condition which is described as a transient monoocular blindness, which occurs from emboli to the central retinal artery of the eye. The pathophysiology of cerebrovascular disease. Now, basically, the pathophysiology can be divided into arterial cerebrovascular accidents or venous cerebrovascular accidents. The venous cerebrovascular accidents are basically due to cortical venous thrombosis. The arterial CV, as I mentioned earlier, could be divided into ischemic CV and hemorrhagic CV. The ischemic CV can be due to embolism or due to thrombosis or due to hypoperfusion. The thrombotic could be due to low flow and thromboembolic. Now, the two major mechanisms that are responsible for ischemia in acute stroke could be thromboembolism and hemodynamic failure. Thromboembolism usually occurs as a result of embolism from the heart or the major vessels like the carotids, or in situ thrombosis in the cerebral vessels, and it leads to an abrupt fall in the regional cerebral blood flow. The hemodynamic failure usually occurs with arterial occlusion or stenosis when collateral blood supply maintains cerebral blood flow at levels that are sufficient for preservation of brain function, that are not sufficient for preservation of brain function under normal circumstances. Now, there is a schematic drawing of different cerebral blood flow thresholds in stroke. The normal range of cerebral blood flow is from 40 to 60 ml per 100 gram of brain. Above 60 is what we call as hyperperfusion, which could lead to cerebral edema. 40 to 20, as the cerebral blood flow decreases from 40 to 20, we call it as oligemia. And that is called as a penumbra threshold. The penumbra is in the demarcating area between infarcted brain tissue and the ischemic brain tissue. And if this is just comparable to the myocardial salvage. If you are able to stop decrease in the cerebral blood flow below this, you will maybe able to salvage a lot of brain tissue. As the cerebral blood flow falls further from 20 to 12, 12 is considered as a critical threshold, and below 12, there is irreversible damage. Below 12 to 8, there is infarction threshold and there is irreversible damage of the brain. Similarly, there are biochemical changes that happen. There is decrease in protein synthesis, HAP72 expression, glucose utilization, lactic acidosis, ATP depletion, which all leads to anoxic depolarization and infarct. Now, this is now an era of COVID-19, and what is the relevance of COVID in cerebrovascular disease? Acute ischemic stroke was infrequent in patients with COVID-19, and it usually occurs in the presence of other cardiovascular risk factors. This is something different from the cardiovascular pathology, cardiovascular manifestations with COVID. But when the patients were discharged to destinations other than home, the death increased twofold with the occurrence of acute ischemic stroke in patients with COVID-19. What are the potential mechanisms of ischemic stroke in patients with COVID-19? It could be due to a large artery atherosclerosis. It could be due to cardioembolism. It could be due to small artery occlusion. It could be various other reasons of undetermined cause. We should also remember that COVID has vasculitis, endothelial injury, hypercoagulability, microvascular thrombosis, cytokine storm, cardiac alteration, systemic hypoxia, and fresh deep vein thrombosis. All these are contributory factors to development of ischemic stroke in patients with COVID-19. This is an aphorism which is given by the neurologist. When stroke strikes, will you be ready? When you see a stroke, be fast. This means that B is balance lost, E is eye slur, F is face drooping, arm weakness, S is speech difficulty. If you find any of this, it is time to call the emergency 911 or your emergency number. Because unless you act fast, if you waste time, there will be irreversible brain damage and the patient may end up being a hemiplegic. Now the treatment modalities have increased so much that if you reach the hospital fast, you can reduce the complications of stroke to a great degree. Thank you.
And the temperature change. Okay, so
Well,
also
Dr.
we
Sushma,
direct
please
from
unmute
the
yourself.
nitrogen and the pulling out. Insert two.
Hello.
Dr. Sushma, you're audible. Go on.
Okay. Good morning, everybody. I'm thankful to PCOS Society for giving me this opportunity, and I'm to introduce our third speaker, Dr. Sanmuga Sundaram. He is a former professor and cardiologist, and he's associated with Bilrath Hospital, Chennai, Tamil Nadu. Today, he is going to talk about pathophysiology and diagnosis of deep. So I request Dr. Su with his presentation.
Good morning, my dear colleagues. Let me share my thoughts about venous thromboembolism that includes deep vein thrombosis and pulmonary embolism, the disease which is often under-recognized and poorly managed. I'll come back and start again. Good morning, my dear colleagues. Let me share my thoughts about venous thromboembolism that includes deep vein thrombosis and pulmonary embolism, the disease which is often under-recognized and poorly managed. If you look at the magnitude of the problem, in the West, it is supposed to affect 1 out of 1,000 persons per year. Deep vein thrombosis in hospitalized people occurs in a very large number. Nearly 40 to 60% of the people who are admitted for medical and surgical illnesses have pulmonary venous thromboembolism, most of which are subclinical, supposed to be commoner among women and among elderly. Originally, it was believed that the occurrence of deep vein thrombosis or pulmonary embolism was less among Asians. This is no longer true. Even data from Indian studies indicate that it is as common as in the West. Even deep vein thrombosis without pulmonary embolism has a mortality rate of 2 to 5% due to comorbid conditions or bleeding complications out of anticoagulant therapy. And the mortality is glaringly high in pulmonary embolism, as high as 10 to 30%, which is much worse than acute myocardial infarction. The morbid event which is attended with this disease is post-thrombotic syndrome, which is supposed to occur in nearly 1/3 of people. If you look at the risk factors for venous thromboembolism, it could be inherited or it could be acquired. Inherited thrombophilic conditions include mutation of factor V, prothrombin, deficiency of naturally occurring anticoagulant substances like protein S, protein C, antithrombin 3, and elevated homocysteine levels, altered fibrinogen level, as well as the functional capacity of fibrinogen. Acquired conditions include surgery, particularly orthopedic surgery involving the lower limbs, trauma, immobilization due to stroke, long-haul flights, malignancy and chemotherapeutic agents, pregnancy and hormones, heart failure, antiphospholipid antibody syndrome, severe liver disease, renal disease, inflammatory bowel disease, connective tissue disorders, and not to forget heparin-induced thrombocytopenia and recently recognized COVID vaccine-related thrombocytopenia with thrombosis. These conditions could be classified as strong risk factors, moderate risk factors, and weak risk factors based upon the odds ratio of developing this disease. Not surprisingly, the fracture of lower limbs, hip knee replacement, spinal cord injury, heart failure and myocardial infarction, and major trauma comprise the most important strong risk factors which have an odds ratio of more than 10. The conventional Virchow triad explains the mechanism of DVT and pulmonary embolism in the diseases which I have enumerated, namely endothelial dysfunction and damage, hypercoagulability, and stasis. In the presence of these three triad situations, ineffective skeletal muscle pump as a result of prolonged bedridden state and impaired venous valve function could contribute to the formation of thrombus in the veins, which may embolize, leading to pulmonary embolism. 96% of the time, it affects the lower limb veins, 4% in the upper limb. Proximal veins are involved in nearly 88%. Deep vein thrombosis confined to cough occurs in a smaller number, nearly 15 to 20% only. Deep vein thrombosis is the source of pulmonary embolism in almost all those who present with pulmonary embolism. You should remember that 50% of symptomatic proximal deep vein thrombosis will have asymptomatic pulmonary embolism. 70% of pulmonary embolism will have demonstrable asymptomatic deep vein thrombosis. What does it mean? When you encounter somebody with deep vein thrombosis, look for pulmonary embolism. And if you have somebody with who presents with pulmonary embolism, look for deep vein thrombosis. As I mentioned previously, roughly 1/3 of people who present with the DVT end up with post-thrombotic syndrome. This is the way a person with deep vein thrombosis have the future course of events. Majority resolve, nearly 1/3 embolize into the lung circulation, and roughly 1/3 end up with post-thrombotic syndrome. Those with pulmonary embolism, only 6% of them will end up with chronic thromboembolic pulmonary hypertension, and rest, the pulmonary embolism, resolve without any consequences to the right heart hemodynamics. Coming to the diagnosis of the disease, clinically, it can be very easily suspected when somebody presents with short duration, sudden onset, rapid onset, unilateral leg swelling with warmth, pain, and tenderness and erythema. Particularly when the entire leg is swollen like this, consider the possibility of DVT rather than cellulitis. Worst situations, people can develop cyanosis as well as gangrene, which is called as phlegmasia cerulatosa. D-dimer is the biomarker to diagnose deep vein thrombosis. Anything more than 500 nanogram per ml is supposed to indicate elevated D-dimer level. For those beyond the age of 50 years, it is better to use age-adjusted upper limit, which is obtained simply by multiplying the age. A patient of 60 years, 600 nanogram will be the upper limit. But the problem with the D-dimer level is it is elevated in many acute medical and surgical conditions like arterial thromboembolism, myocardial infarction, stroke, acute limb ischemia, inflammatory diseases like sepsis, COVID-19, hepatorenal diseases, surgery and trauma, malignancy, thrombolytic therapy, even physiological situations like pregnancy can elevate D-dimer level. This is to say that a negative D-dimer carries more weightage to exclude the disease rather than a positive or elevated D-dimer level. The imaging test for diagnosis of deep vein thrombosis is the Doppler scanning of the lower limb veins. One can demonstrate the thrombus filling up the vein. The veins get distended. Veins cannot get compressed by pressure from the probe, and color Doppler may demonstrate lack of flow or disturbed flow in the thrombosed vessel. You can do Valsalva maneuver and demonstrate lack of increase in vein size if veins are filled up with the thrombus. And calf muscle compression is supposed to augment the flow in the proximal veins. If the proximal veins contain thrombus, the augmentation does not happen. These are the ways to diagnose deep vein thrombosis with the help of ultrasound and Doppler facility. It is having a very high sensitivity, 94% for proximal disease, which is obviously poor for distal vein thrombosis, particularly the calf vein thrombosis. Specificity is as high as 94%. There are certain issues with the venous ultrasound. Isolated iliac vein thrombosis, which occurs in a very small proportion of people, less than 1%. But this is supposed to be commoner in people with pregnancy, pelvic surgery, and malignancy. The diagnosis is not very straightforward with the venous ultrasound. Similarly, difficulties can be encountered to differentiate between acute and chronic venous thromboembolism. Venous distension and hypoechoic thrombus material indicates acute onset, while hyperechoic thrombus, thickened wall, presence of collaterals, etc., may indicate a chronic disease. Whenever we tend to seek the help of investigations, we need to look at the pre-test probability for deep vein thrombosis. Wells probability score is a well accepted one. Each one of the parameters, namely the malignancy, paralysis, lying down in the bed for more than 3 days, major surgery within the last 4 weeks, tenderness, swelling of the leg, pitting edema, collateral superficial veins, carry 1 score each, while when alternative diagnosis is more likely, it carries -2 score. Add everything together and you get the number with which you say it is high probable or moderately probable or low probability for deep vein thrombosis. Once you have the well score, your algorithm goes like this. If the pre-test probability tells you that it is a low probability situation, go for D-dimer estimation. If it is normal, we can safely rule out deep vein thrombosis. If it is elevated, you need to go for proximal leg vein Doppler test. If it is moderate to high probability situation, you can directly go for the imaging test. If it is positive, treat as DVT. If it is negative, then go for D-dimer. If it is normal, you can exclude it. And if it is positive, you need to repeat the ultrasound after 3 to 7 days. And if it is positive, treat it as DVT. And if it is negative, even after 1 week, you can safely exclude the diagnosis of DVT. As I mentioned, roughly 20 to 25% of people with DVT or pulmonary embolism have inherited thrombophilias. Do we need to test for thrombophilia in all? Certainly not. People who have recurrent venous thromboembolism, unprovoked venous thrombosis, family history of venous thromboembolism, people who have combined arterial and venous thrombosis, people who have had history of fetal loss need to undergo testing. But there are many pitfalls. The normal ranges are very wide. Sometimes you may have to repeat the testing to confirm the thrombophilia. Pregnancy itself may mimic factor V mutation because of resistance to activated protein C. Pregnancy and oral contraceptive pill may lower protein S level. Antithrombin 3 level is decreased in acute thrombosis after heparin administration and preeclampsia. Protein C and S are reduced by warfarin therapy. So obviously, if you need to do blood sampling to confirm thrombophilia, it has to be done before we give any anticoagulant to people with suspected deep vein thrombosis or pulmonary embolism. To discuss about something which is important for the audience, namely DVT in pregnancy, it's a procoagulant state because of increased factors, coagulate factors 7, 8, 10, fibrinogen, and PAI1, and decreased protein S level. It's a procoagulant state. There are many risk factors which go with pregnancy, namely hyperemesis, multipara, multiple pregnancy, family history of venous thromboembolism, age more than 35, obesity, assisted reproductive techniques, preeclampsia, cesarean section, postpartum hemorrhage, abruptio placentae, transfusion, immobilization. All of them are likely to enhance the procoagulant state of pregnancy and make them more prone for DVT. Wells scoring is not well tried out in pregnancy, but there is a simple scoring known as left score. L stands for left leg symptoms because of more common occurrence in the left leg, edema being unilateral, and first trimester. Each one carries one score. If it is 0 or 1, the likelihood is less. If it is 2 or 3, the likelihood is more, based on which you can go for D-dimer testing and imaging. You need to assess the risk of recurrence, particularly when you are trying to stop the therapy at the end of 3 to 6 months. You have certain protocols again, what is known as HER2 rule, hyperpigmentation, edema, redness. Any one will carry 1 point. D-dimer more than 250 or 500 at the end of anticoagulation therapy, obesity, and older age. If the score is 2 or more, you need to consider long-term anticoagulation. What is the relationship of PCOS with the DVT? Higher occurrence because of obesity, administration of oral contraceptive pills among them. Prothrombotic milieu exists in people with PCOS, and insulin resistance is another one which favors DVT. Studies have confirmed that PCOS has increased chances for developing DVT and pulmonary embolism, the odds ratio being ranging from 1.7 to 1.9 in different studies. Coming to the much feared complication of DVT, namely pulmonary embolism, the clinical presentation, high risk, intermediate risk, or low risk, depends upon the underlying cardiorespiratory status or the diseases and the magnitude of the pulmonary embolism. In addition to the thrombus load, the chemical mediators which are released by the thrombus and coexistent inflammation would cause vasoconstriction, bronchoconstriction, ischemia would lower the surfactant leading to atelectasis, all of which will lead to worsening of hypoxia, and RV acute RV overload will result in cardiogenic shock, both of which could result in higher mortality. You have something like the Wells score for DVT. We have revised Geneva prediction rule for pulmonary embolism. You need to apply that and assess the likelihood of pulmonary embolism who presents with dyspnea with or without DVT. Though electrocardiogram and chest X-ray had been extensively used to diagnose pulmonary embolism, the parameters are insensitive and non-specific. They are more often useful to exclude simulating conditions like myocardial infarction, heart failure, and pneumonia. Echocardiogram to a certain extent by demonstrating RV overload, McConnell sign, that is, contraction is well preserved in the apex while the free wall is not contracting. It is supposed to be one of the important pointers for pulmonary embolism, though not 100% specific for pulmonary embolism. Demonstration of tricuspid regurgitation. You can also demonstrate thrombus in the right ventricle, thrombus in transit. Sometimes IVC may show the thrombus material. But the test for confirming pulmonary embolism is CT pulmonary angiography, except subsegmental pulmonary emboli. All the other situations can be very confidently diagnosed by CT pulmonary angiogram. With the widespread availability of CT pulmonary angiogram, the role of ventilation perfusion scan is coming down. You should remember that as high as 30 to 40% of them, the result is very inconclusive. This is the reason for many of us choosing CT pulmonary angiogram as the gold standard for diagnosis of pulmonary embolism. But there are certain situations like pregnancy, people with renal disease where you cannot use iodine contrast. VQ scan may still be useful for diagnosis of pulmonary embolism. Based upon the hemodynamic stability, the severity of pulmonary embolism, the presence of right ventricular dysfunction on echo or CT scan, and elevated biomarker, namely troponin, people with pulmonary embolism can be classified into high, intermediate risk, and low risk, based upon which the therapy is going to be decided. About the therapy, my colleague will be talking to you. To sum up, DVT and pulmonary embolism is relatively a common disease. If not treated early, if not recognized early, the mortality is quite high. The diagnosis should not be based upon only the laboratory studies. It should be based upon some clinical prediction algorithm, based upon which you need to choose the appropriate biomarker, whether it is a biochemical biomarker or imaging biomarker. You need to exploit them properly and come to conclusion. Thanks for listening.
Thank you very much. So thanks again to all the speakers. May I now request Professor Mohanan to speak a few words, the President of Cardiological Society of India.
Thank you, ma'am. Thanks for the opportunity, PCOS group, and the Cardiological Society is grateful to you. It's true that the cardiovascular disease is the leading cause of mortality and in women, and in 2019, 35% of death in women were due to cardiovascular disease. But despite whatever progress we have made in the era of in this century, the diagnosis awareness, there's a continuing stagnation happening. What the need of the hour is an early detection and targeted management. And of course, we are going to discuss, my erudite cardiology colleagues are here to discuss with us about especially concentrating on PCOS, but then we will be also looking at the other risk factors of coronary heart disease, both arterial side and the venous side. And I wish the conference the very best, and I'm sure we will also learn from you. Thank you.
Thank you very much. I would now leave the webinar open for discussion. Do we have any questions posted?
It has been a very we don't have. You can go ahead with what questions you have. And as we get questions, we'll inform you.
Okay. So maybe Dr. Bakshi also has some questions, but I had one or two questions from my side. The first question I wanted to ask our first speaker, Professor Meena. Sir, you said that there is a misconception amongst women about, is he there?
Don't worry. You shoot your question. We will try to handle it. We are three
Okay.
guys around. Don't worry.
Yeah.
Dr. Meena is
So
there, Mohan
he showed in his slide that it is a misconception that women are protected from cardiovascular diseases in the premenopausal stage. Is that right? Because I thought, but then he also said that estrogens are protective, etc. So I was wondering why he said it's a misconception.
Maybe there is possibly some correction, because women are generally protected, because we know that there is a translational analysis of the hormones protecting your endothelium, unless you are a diabetic. Diabetic women they lose their protection. Of course, postmenopausal, definitely no administration of estrogen will help you, but premenopausal women are generally protected against cardiovascular disease.
Yeah, I would also add, can I add a word?
Please.
Yes.
See, as you said, there seems to be some protection in the women and the premenopausal age. But as Mohan said, there are three situations where women lose their protection. One is a diabetic state, the other is a dyslipidemic, familial hypercholesterolemic state, and the third is the PCOS itself. Because as far as you are concerned, PCOS is a syndrome where you have, it's equivalent to metabolic syndrome that we deal with. So you have insulin resistance, you have hyperdyslipidemia, and all the factors which are prone to develop atherosclerosis. So I think women with PCOS certainly come under a high risk group as far as we are concerned. So that's very important. And so the premenopausal age, this is again a very important group where we need to concentrate on these aspects. When you plan the management of PCOS, it was to be a combined decision with the cardiologist and the obstetrician and gynecologist to manage PCOS, because it's extremely important. We have two facets going hand in hand.
So there's another cohort of patients which we gynecologists deal with very often, that is the premature ovarian failure. And they are like, sometimes you find premature ovarian failure as young as 20, 25, 19. So we always have it in our mind that we should give them hormone replacement therapy, but patients are not very regular with it. So my question in my mind is how long we should prescribe them hormone replacement therapy, so that they derive, apart from having all the hormonal benefits, whether the body or the sexual function, etc. From the cardiology point of view, protection, how long should we prescribe them a hormone replacement?
I think
there is a Lancet Commission of Protection of Cardiovascular Protection of Women formed in 2020, where they have given us an extensive, what all things that has to be done. There is no specific mention about the duration of the HRT or what, but it's said that try to limit your extraneous hormonal therapy to the minimum period. There is no such thing that you continue it for 6 weeks or 12 weeks. It's not mentioned. But this is very particularly mentioned. Keep it to the minimum.
Should we not prescribe them till they are at least 40, 45? Is that?
But it looks sensible.
Yeah.
Or Shanmugha.
No, actually, there is a study called HERS, the HERS study, where and the HERS did not show any benefit of giving estrogen to these people beyond a particular age. So I think it is probably best left to the gynecologist to decide how long you should give, because it does not offer any cardiovascular protection beyond this. So I think
so it's I think a gray area where we also don't know how to treat the patient. Right. Another question I heard from you all in your lecture, I think the second speaker, Dr. Venugopal, you said that initially it was thought that in Europeans the chances of stroke is very high, but now even Asians have caught up. So is it because of the increased obesity, lifestyle? And also I was surprised to see, I am from Orissa, I am from Bhubaneswar, that Orissa and the Northeast has the highest stroke risk in India.
Yeah.
What do you think could be? We are, why are we at such high risk?
See, I do not know the exact reason. As I told you, I'm a cardiologist, not a neurologist. And I got the data from a neurologist. The thing is that, see, we have to remember that all the risk factors for whether it is cardiovascular or whether it is cerebrovascular. The essential pathology is the same. And we in India have the highest number of hypertensive, the highest number of diabetics, highest number of dyslipidemics. So we constitute a population which is prone for atherosclerosis. And therefore, that is why we are now catching up with the West. And actually, if you look at the stroke rates in other countries, India is far more higher than the US and the European countries as far as the stroke risk is concerned. To answer your question on West Bengal, Orissa, and this thing, I am not very sure because this is the data given to me. But probably it may be that awareness and treatment of risk factors like hypertension and this may be.
And that is what, Venu, I will just jet in because we have, madam, we have a divergence here. For example, you see Kerala, Punjab, and Tamil Nadu having maximum incidence of coronary artery disease, and the northeastern people having maximum number of stroke. And it has been found out that the incidence of hypertension, if you take, it's about some 21 to 25% in the southern state, while it goes nearly 35, 37% in the northeastern states. So basically because of very many reasons, and you possibly cannot
could be ethnic and racial, ethnic differences.
And maybe although even the salt consumption is supposed to be something like about 18 grams, where the recommendation by WHO is 5 grams. So there could be very many reasons, but this may be one of the reasons why you have more strokes in that area.
Generally, we have been blamed for the typical siesta habit after eating the rice and but then siesta habit is very common in Italy, etc. But they are, I think, one of the healthiest cardiovascular wise. So anyway, Dr. Bakshi?
Yeah. Hello.
Go ahead, Dr. Bakshi. You're audible?
Possibly she's using two devices.
There is.
On, you need to off one of the device.
Yeah, I'll do that.
Sujata, till the time you can go ahead with the next question.
Okay. So then apart from, one sec, I think mine is it muted?
You're audible.
I'm audible. Okay.
Yeah,
I'm next thing I had in
my,
I was wondering, you said something.
I wanted to ask Dr. Sundaram is that the risk of pulmonary embolism, is it more with chronic and partially occlusive thrombus conditions?
No, acute DVT is more prone for embolization. Chronic ones get organized, they are less likely to embolize. Acute ones are more vulnerable.
Okay, I think, is she there?
Yes.
Yeah. And another question to all the panelists is that since we know that polycystic ovary per se forms a higher risk for all three conditions, do we have any specific and special preventive strategies right from pregnancy where the risk is higher onwards for cardiovascular, stroke, and thrombosis events?
I think the most important thing as far as PCOS we are concerned is lifestyle modification. See, I think both of us, both the gynecologist as well as the cardiologist, emphasize on lifestyle modification, weight reduction, regular exercise, diet control, all these things. Beyond that, if we did it specifically, we would target the risk factors in each. Like, for example, a patient has got dyslipidemia, you treat the dyslipidemia. A patient has got hypertension, you treat the hypertension. So it's a composite of lifestyle modification plus targeting the specific components of the PCOS that each patient has. Probably you cannot have a single one pill for every illness. This thing for each. I think each patient has to be treated separately, and you have to assess the risk factors.
Certainly, but the lean PCOS are more commonly exposed. I mean, is the risk different between lean PCOS and the obese PCOS?
Generally, the risk heightens with the obesity. Now we know that there is a clustering of insulin resistance, obesity, and metabolic syndrome. Everything gets augmented when you're obese. But then, even as you said, there is a lean PCOS also, which is possibly not the commonest variety. PCOS by itself augments the cardiovascular risk, and when they become obese, well, the risk heightens. As Venu said, have a healthy diet and exercise, please.
Yes, thank you. Thank you for that. Dr. Sujata, please.
I was having another very gray area where I wanted your opinion. Again, in PCOS women, prescribing oral contraceptive pills for various menstrual abnormalities is, I think, is the mainstay of treatment. We have to prescribe them oral pills very, very often and sometimes very long period. So I was wanting your opinion again. Is there any guideline which we can follow as to how long we can give them? PCOS being an inherent problem, because OC pill has been shown to be pretty safe on a long term in the general studies that we have, the nurses studies and all those 10, 15, 20-year studies that have shown OC pill to carry kind of not very, very high risk. But in PCOS, do we have any suggestion similar?
Again, there are no specific recommendation about the duration. It's again mentioned that, well, as you said, the lower dose varieties of your pills are possibly the best lot and the best studied. And people have been using these OC pills also for a sizable period in PCOS group. But as I said earlier, there is no definite mentioning about what is the ideal duration of these pills. No.
Sometimes
I think,
we have
you are the best
5, 10 years. Yeah, yes, yeah, that's the thing. Okay.
If it is for contraception, progestin alone, contraceptives seem to be better than a combination of estrogen and progesterone as far as thrombosis is concerned. That is the one area which is.
Yeah, usually after 35, we don't prescribe in PCOS women. But even young girls, you need that is the combination pill very often. So, and you give them for 6 months, again they come back. So we are always in doubt how long can we give. Another thing was, doctor, you said something about the LEFT score in pregnancy. I couldn't catch that. Could you elaborate?
L stands for left. Because in pregnancy, DVT is supposed to be more common in the left leg.
Okay.
Then E stands for edema. One leg size is more than the other by more than 2 centimeters, one score. FT stands for first trimester.
So they are at a higher risk in the first trimester, is it? Okay.
I mean, the left scores, says like that. But when I, looked at other articles, it seemed to be like, uniformly divided among all the 3 trimesters.
Yeah.
But left score gives, priority for the first trimester.
Okay.
Claiming
and
that it is more common in the first trimester.
T is that first trimester.
Yeah.
Okay. Thank you. Thank you. So do we have any questions? Let me check.
I just wanted to add that, Dr. Sujata, you said that after 35, we generally don't prescribe OC pills, but there is a segment of population of ART who is exposed to very high dosage of hormones for their IVF and frozen embryo transfer and all that. Unfortunately, not much of the studies on this cardiovascular risk is there, but I think we need to focus on them also.
Very much, very much. I think, would you advise us gynecologists to go a little more liberal on anticoagulants?
That's my question too.
Post-operatively, anybody more BMI, this, that. I have kind of, after seeing one patient with likely post-operative thromboembolism, I have also started thinking that maybe I should more liberally prescribe anticoagulants post-surgery.
The basic problem with us doctors are, we are always obsessed with the risk of bleeding. Now,
Yeah.
for example, the same thing happened to us in atrial fibrillation, elderly population. These are the dangerous combinations, but the proportion of warfarin use was phenomenally low. But now with the newer drugs available, that risk is prevented to an extent. I will still say that bleeding risk, you have to gauge your assess your ischemic versus bleeding risk. But absolutely, thromboprophylaxis should be in order whenever you are facing with a high-risk patient.
Totally. I think this message also should go down to the gynecologists that one should, open up our minds and at least thromboprophylaxis should be given even in IVF, etc.
I think it is time now for you to go to the next session.
Yes.
Yes.
I think there's one question. It's also seen in puparium. That's what Dr. Meena, she's the observer from the Maharashtra Medical Association. Does smoking in young girls give them a protection against coronary artery disease?
My God.
No, it's the other way around.
Why would it give protection?
Because actually, if you see the data, women who smoke have a much higher risk of coronary artery disease and fatalities when compared to women who do not smoke. So smoking, actually, there is no protection. Actually, it's harmful. And this is one of the reasons why women have started having more premature coronary arteries in a younger age group, especially in the Western population, because they tend to smoke much more when compared to the Indian population. This is one of the reasons attributed.
And now Indian girls are also catching up.
Yeah, no smoking, please.
Thank you very much to all the speakers and Dr. Mohanan. Thank you very much.
One more question. Is the risk of thromboembolism higher during the puparium?
Sundaram?
Yeah, well, actually, if you look at the critical periods, the most critical period is the first week of puparium, and it goes on till 6th week after delivery. Yes, the high risk period.
Okay, thank you. I think we have to go. Yeah.
Bye-bye.
Bye-bye.
Madhuri, you're muted.
I thank the moderators, both Sujata and Dr. Sushma, as well as all the three speakers, Dr. Chandra Van, Dr. Venugopal and Shanmukh Sundaram, for the excellent lectures and the interaction we had. We now go on to the second session, which is on PCOS and cardiovascular disease. I invite two moderators, Dr. Padma Rekha Jirke, who is the scientific director of Shushruth Conception Clinic and Shreyas Hospital, Kolhapur. She's the editor-in-chief of Journal of Human Reproductive Sciences, the vice president of the Fertility Preservation Society of India, and the executive vice chairperson of the Maharashtra State Chapter of ISAR, as well as the managing committee member of PCOS Society of India. She has several publications, both in national and international journals, to her credit. We have the next slide. We have a second moderator, Dr. Gauri Karandikar, who's the director of Karandikar Hospital, Nasik. She's the director of Growing Up Clinic Adolescent Care Center at Nasik, vice president of the Nasik OBGYN Society, and the national trainer for adolescent-friendly health services. She's also the member of the Perinatology Committee of FOXI and the Adolescent Health Committee of FOXI. She is member of the International Member Society for Adolescent Health and Medicine and of the National Cell for Violence Against Women. She's also the member of the Mission Pink Health Adolescent Health Initiative of the Indian Medical Association. She is been awarded with the recipient of Young Doctors Award by FOXI. Her areas of interest include adolescent health, high-risk pregnancy, and protection against violence in women. I hand over the session to Dr. Padma Rekha and Dr. Gauri Karandikar.
Very good morning, and thank you, Dr. Madhuri, for this introduction. And I would like to congratulate the Cardiological Society of India and PCOS2 Society for coming up with such a wonderful webinar and a workshop on this important topic, especially on the eve that on 29th September, that is a World Heart Day. The theme for this year is Use Heart to Connect. And here we are using this digital platform to connect cardiovascular disease with PCOS, which is one upcoming pandemic, we could say. I would like to introduce our first speaker for today, Dr. Professor Govindan Unni, who is he's affiliated to the Cardiological Society of India, the Indian College of Cardiology, and the Hypertension Society of India. And he has been an outstanding academic career and has been recognized as the inspiring cardiologist by Economic Times in Doctors Conclave 2018, and is a recognized PhD guide of Kerala University of Health Sciences, and has a number of publications and has been a part of a number of major studies in the field of cardiology, and his areas of interest being clinical cardiology, preventive cardiology, heart failure, hypertension, and atherosclerosis. I welcome you, Professor Unni, and we could proceed with your talk.
My dear friends, the question that I am going to answer today in the next 15 minutes is, does PCOS increase the risk of cardiovascular disease? Now, as we all know, probably insulin resistance is the crux of the matter. Because even though insulin resistance is not part of the diagnostic criteria for PCOS, it is seen in about 95% of obese women with PCOS and about 75% of lean women with PCOS, telling us thereby that it seems to be, at least in part, independent of obesity. Insulin resistant and hyperinsulinemia are well known to increase the risk of CVD, not only in PCOS, even otherwise. They are well known to increase the risk of cardiovascular diseases. However, studies on the degree of CVD risk in women with PCOS versus general population shows a mixed bag. Contrary to what we believe that there should not be any confusion, there is some confusion if you study the degree of CVD risk in PCOS versus the general population. It is generally accepted that the CVD risk in PCOS is explained by the traditional CVD risk factors, and the absolute risk conferred by PCOS is not very high. However, it must be understood that the CVD risk is not uniform across all women with PCOS diagnosis. It depends on the phenotype of the PCOS. It depends on the ethnicity of the PCOS woman. So it is greater among certain PCOS subtypes and certain ethnicities also. For example, Hispanic PCOS women have a more severe phenotype, and non-Hispanic Black women have probably the mildest phenotype. Hyperandrogenic and anovulatory phenotype is probably the most insulin resistant, with more of BMI and more of central adiposity. Okay, with that introduction, let me now come to the CVD risk factors in PCOS. Let me start with dyslipidemia. The dyslipidemia in PCOS is characterized by elevated triglyceride, elevated VLDL, and low HDL cholesterol. LDL may be elevated, but not very high. This is the classic atherogenic dyslipidemia or diabetic dyslipidemia, which is usually associated with insulin resistance. So the LDL concentration is not very high. It can be normal or maybe borderline high. But the quality of the LVL, unfortunately, is very bad. The LDL predominant is the small dense LDL, which is much more atherogenic than the large buoyant LDL, which is less atherogenic. So in PCOS women, even though LDL is normal, the small dense LDL particles predominate. Similarly, the oxidized LDL, which is more of a malignant form to produce atherosclerosis, is in higher concentration in these people. Next CVD risk factor, equally important, is glucose intolerance and diabetes mellitus. Approximately 35% women with PCOS have impaired glucose tolerance, whereas about a tenth, in fact 7.5 to 10%, have type 2 diabetes mellitus. On the other hand, conversely also is true. If you take women with type 1 diabetes or type 2 diabetes or gestational diabetes, the prevalence of PCOS is increased in these people. And it is also related to obesity, because as obesity increases in PCOS, there is a substantial increase in diabetes mellitus also. However, it must be understood that even among lean women with PCOS, there is increased risk for diabetes mellitus. This position statement from the European Society of Endocrinology recommends oral glucose tolerance test in all obese PCOS women. In lean women, again, oral GTT is recommended in those who are above the age of 40 years, with a positive history of gestational diabetes or a family history of type 2 diabetes mellitus. There is no routine recommendation for doing either insulin concentration or the indices of insulin resistance, nor is there any recommendation for using HbA1c as a screening test. There is no evidence, unfortunately, on when exactly we should screen these people. But as a consensus, it is arbitrarily suggested that these women should be screened every 3 to 5 years, even if they are not a diabetic. The next important CVD risk factor is hypertension. And like diabetes and dyslipidemia, it has got a high prevalence in women with PCOS, 65% compared to 41% in control. Hypertension in PCOS is not associated with BMI. It is actually the result of renin-angiotensin-aldosterone system activation, basically increase in aldosterone, a hyperaldosteronic state. Not only is hypertension more prevalent in PCOS, but the quality of hypertension or the variation in hypertension is also different. Normally, there is a nocturnal dip in hypertension in a normal person, whereas in PCOS, it is found that as far as systolic BP is concerned, 51% do not show the nocturnal dip, and as far as diastolic BP is concerned, 23% do not show the nocturnal drop. The PCOS during reproductive age confers actually a higher risk of hypertension even in the post-menopausal group. Overweight and obesity, the next important risk factor, is very, very, very frequent in women with PCOS. Not only is overweight BMI, but the waist-hip ratio is also higher in these women. And this all metabolic aberration, whether it is diabetes, hypertension, or dyslipidemia, worsen as the woman becomes more and more obese. And it can be attributable to the underlying insulin resistance. Metabolic syndrome, which is defined by the presence of any three of the following, which is elevated waist circumference, 102 in men and 89 in women, triglyceride more than 150, HDL less than 40 in men and less than 50 in women, blood pressure more than 130 systolic or 85 diastolic, and elevated fasting glucose of more than 100. If you have more than 3, you are classified as metabolic syndrome. And the prevalence, the odds ratio for prevalence for metabolic syndrome is 2.88 in women with PCOS, which means about 3 times higher than the general population. Of course, like all what I had said, there is significant heterogeneity here also, and the underlying problem probably is insulin resistance. Obstructive sleep apnea. Again, obstructive sleep apnea is not due to obesity alone. Even after controlling for body mass index, women with PCOS still have 30-fold more likely to have sleep disordered breathing. Another less important but CVD risk factor in PCOS is non-alcoholic fatty liver disease. Now, we have been talking about traditional CVD risk factors. Let us look at some emerging risk factors, which is activation of the sympathetic nervous system, which has an adverse impact on cardiac structure and function in hypertension as well as in the general population. And in PCOS, this could be the underlying cardiovascular abnormality in women. But another important emerging risk factor is chronic inflammation. Because arteries get inflamed, there is arterial inflammation in response to injury triggered by LDL cholesterol, cigarette smoking if it is there, and hypertension. And this prolonged persistent exposure to inflammation can lead to subsequent plaque formation and rupture. Oxidative stress, another important emerging risk factor, is an imbalance created by the excess production of oxidants and the lesser presence of antioxidants. The role of reactive oxygen species in the various signaling pathways that underlie vascular inflammation and atherogenesis is also now being increasingly discussed. So this is also found to be more prevalent in women with PCOS. Vitamin D deficiency is also another important emerging risk factor. Do not forget oral contraceptive pills, because oral contraceptive pills are given in women with PCOS because they are effective in reducing hirsutism. They induce regression of male pattern alopecia and restores cyclic bleeding. However, OCPs, remember, deteriorate cardiovascular risk and metabolic profile, and hence use of OCPs in PCOS women is a matter of concern. So we have PCOS, which produces traditional risk factors and emerging risk factors. Traditional risk factors being obesity, diabetes, hypertension, dyslipidemia, and emerging risk factors being activation of sympathetic nervous system, inflammation, oxidative stress, and vitamin D deficiency. All these together produce a subclinical CVD and then clinical CVD. So let us look at subclinical CVD. Probably one of the most studied subclinical target organ cardiovascular damage is coronary artery calcium scoring. And it has been found that it is more prevalent in women with PCOS. Even if you take elderly women with PCOS, coronary artery calcium scoring is higher in this group. Carotid intima media thickness is another subclinical target organ damage, which has been found to be higher in women with PCOS. And then you have pulse wave velocity, which is actually a measure of the elasticity of aorta, which is also higher in women with PCOS. And then you have markers of chronic inflammation like CRP and homocysteine, which are also significantly elevated. Again, let me remember that in all these things, there is a high degree of heterogeneity depending on the phenotype as well as the ethnicity of the woman. And coming to the last important part, that is clinical CVD risk. Unfortunately, or rather fortunately, the evidence is conflicting. We would have expected that with this amount of risk factors, this amount of subclinical CVD, we would have expected significant increase in clinical CVD. But the evidence is conflicting. Does PCOS independently increase the risk of clinical CVD events? Is a question which merits answer even now. There is significant risk factor for CVD, there is no doubt, regardless of the BMI. But it depends on the phenotype of PCOS, and there is heterogeneity, not only in the clinical presentation of PCOS, but also in the CVD risk conferred by PCOS. And that is why probably the reason why there is conflicting evidence with respect to PCOS and clinical CVD risk. This is probably one of the latest studies published in the Journal of Endocrinology and Metabolism. Women with polycystic ovary syndrome having an increased risk of major CV events, a population study. And you can see that if you look at survival, which is the y-axis, and the years from the index date as far as the x-axis, whatever you look at, whether it is a composite endpoint, myocardial infarction, stroke, angina, revascularization, or CV-related mortality, the dark line, which is cases, which is patients with PCOS, comes lower down, or survival is less in them compared to the lighter line, which is actually the controls. The same is true in the sub-study of the WISE trial, which is the Women's Ischemia Evaluation Study, where they found that women with PCOS have a large number of CV events. Multi-vessel CVD was observed more in PCOS women. Event-free survival, including fatal and non-fatal events, was significantly higher in PCOS women compared to non-PCOS women. And the difference between the two groups became higher when stroke was also included, telling thereby the relationship between PCOS and stroke. So we have these two studies which show that the risk is high in women with PCOS. On the other hand, we also have this large 21-year controlled follow-up study of cardiovascular disease and risk factors in women in the postmenopausal age. And it is interesting to note that if you look at 1987, when the trial started, look at the p-value, the thick p-value numbers for triglycerides are higher, HDL is lower, LDL is higher, and systolic BP is also higher in women with PCOS. 21 years later in 2008, look at the p-values and you can see there is no difference between PCOS and control, except maybe in triglyceride, where there is a slightly statistically significant. All the other risk factors have leveled out between PCOS and controls. You can see the p-values there. With the result that when you look at cardiovascular events, whether it is hospitalization due to MI or age at MI, whether it is hospitalization due to stroke or age at stroke, or all CVD, you can see there is no difference. The p-values are absolutely non-significant, PCOS versus control. Looking at mortality, the story is the same. If you look at the deceased during follow-up or the mean age at death, again, absolutely no difference in the p-values. So CVD events in aged PCOS patients are similar to those without PCOS or only marginally increased. It is anyhow lower than what was expected on the basis of risk calculation during the younger age. This discrepancy is, however, very difficult to explain. The mechanisms are unclear why there is a lot of CVD risk, but the events are less in patients with PCOS. Maybe there is progressive normalization of risk factors during late reproductive age, as was shown in the last study, where the risk factors became same by 2009. Moreover, in the majority of cases, the severity of PCOS reduces during lifetime due to spontaneous reduction of ovarian and adrenal androgens. Risk factors are more, there is no doubt about it, and they cluster in PCOS, but PCOS becomes milder with increasing age and probably disappears later after menopause. The cardiometabolic abnormalities, however, it has been found, can exist or can prolong beyond the onset of menopause. But it has also found that women with PCOS enter menopause at a later age, and that could be a protective effect on the development of atherosclerosis and the risk of future events. So it is very difficult to explain, but there are umpteen mechanisms. So my dear friends, ladies and gentlemen, let me conclude here by trying to answer this very difficult question. How is it possible that so many risk factors for CVD cluster in PCOS at an early age, yet does not seem to translate to an increased risk for CVD in later life? Well, the first part is correct. There is early worsening of risk factors, but it does not seem to progress. That is a fact. It could be that women are aware of these risk factors in early age, take action, and so anticipate the events, and so reduce the risk factors. Whereas in the control group, they develop metabolic abnormalities gradually over time and end at a similar level as women with PCOS, as we saw in the last study. Moreover, there has been genetic variation in PCOS women, so that they have a later menopause, they have a better DNA repair and maintenance, and that could possibly explain the reduced cardiovascular event rate in PCOS. So risk factors are more, it is a fact, but event rates possibly is less. It is still, there is still, as I said, some trials showing that the event rates are high, but the evidence is conflicting. So I conclude here, and thank you very much for the opportunity for me. Thank you.
Professor Oni. Madhuri, my video is not starting. I think you can all hear me. Thanks for such an excellent covering of a very difficult and challenging topic. We will come during discussion and we will discuss whatever questions have arisen out of this talk. We now invite Professor Prafulla Kelkar to speak on how does one assess the risk for cardiovascular disease. He's Professor and HOD of Cardiology in KM Hospital, Mumbai, and is Professor Emeritus at present. He's Guidelines Committee Chairperson of Cardiological Society of India and has had several publications in national and international journals. CSI guidance document on acute MI and HF care during COVID, he has contributed to that. He's chairperson of Board of Studies, Maharashtra University of Health Sciences, chairman of Pinnacle India Registry in collaboration with ACC, former president of CSI Mumbai chapter and organizer of CSI Con 2018, researcher and trialist for various trials, as we can see on the slide. And it's an honor to have you, sir, here. And we will all be enlightened with your knowledge as to how we go on about assessing the risk for cardiovascular diseases in women with PCOS.
Well, thank you, Dr. Parmar. Hello, am I audible there? Yeah.
Yes.
Yeah, may I share my screen? Thank you so much for that kind introduction. And at the outset, a big thank you as well as congratulations to the PCOS and the CSI. Especially, let me make a special mention about Dr. Madhuri, my close friend from medical school days, and also Dr. Duru Shah as well as Dr. Mohanan. So good morning to you all. And my slides are visible now? Yeah. And here I go on a slideshow. Am I good to go? Yeah, so my job has been made easier by the previous speaker, Professor Unni. He has said that cardiovascular risk is increased in women with PCOS. So my job is to, how do you, as a gynecologist, go about assessing the cardiovascular risk? In other words, how do you become lady cardiologists, or for that matter, cardiologists to the ladies, not only ladies with PCOS, but all your patients? That is my job. So having said that, by cardiovascular risk, when I say cardiovascular risk, I would be through this lecture talking about atherosclerotic cardiovascular disease risk assessment. And let's take a typical scenario that's coming into your OBGYN OPD for a follow-up. A 41-year-old female who's a known case of PCOS and is on treatment, has recently got diagnosed to have diabetes mellitus, is obese and has got typical metabolic syndrome. And however, now she complains to you of atypical chest pain and heaviness. So how will you go about, how will you proceed to assess her cardiovascular or ASCVD risk, in other words? So before we do that, why do we have to assess this risk? Primarily, to be able to prescribe to her and be preventive about her, prescribe to her if she is at the low end of the spectrum in terms of her 10-year ASCVD risk, which is, if say it's less than 5%, then you will prescribe her mere healthy lifestyles. At the other end of the spectrum, if she's very high risk, has got more than or equal to 20% risk of getting a cardiovascular event. By a cardiovascular event, we mean either non-fatal stroke or a stroke, fatal or non-fatal, or a coronary artery disease event, a heart attack, so to say, or an ACS phenomenon, established coronary artery disease she develops. Again, as also a cardiovascular death. So this is the three hard outcomes that we predict her future. And whether she belongs to the intermediate risk group, and whether it is just, we can have just engage into a discussion and not necessarily prescribe primary preventive therapies. By primary preventive therapies, we mean statins and aspirin. And we could resort to other further workup, so to say. Or for that matter, whether she is a negative risk factor. Okay. By that, I mean, for instance, if you have done a coronary artery calcium scoring and she's got a 0 score, we can confidently tell her that she no longer needs any preventative therapies. And finally, very often, some of them might have first-degree relatives who have been having high ASCVD risk. And how do we go about counseling that patient? So having known the why of it, how do we go about going it? We have to look at what Dr. Uni talked about, the traditional risk factors as were described in the Framingham study way back in the 90s. Hypertension, and somebody was talking about cigarette smoking in your young or 30 to 40 age group PCOS patients is extremely high risk factor. And then diabetes mellitus, dyslipidemia, premature family history of ASCVD. By that, you generally mean that her close siblings or her parents have had ASCVD diagnosed at the age less than 55 in men and at the age less than 65 in women. But women are fast catching up, and with the Indian phenotype, for Indian ancestry people, for South Asian ancestry people, we could take that as occurring 10 years earlier. Then obesity, which our patient is also. Then once we have looked at the traditional risk factors, then we should order a lipid profile for that patient. And this is the crux of the talk, either informally for the young people, informally we say, because these are all, we go about calculating their risk by using what is known as a risk calculator. Now, in keeping with the theme of the WHO for this year, for the World Heart Day, for World Heart Day Federation theme, digital, you connect with your devices to risk factors. These are available on mobile apps, as you will see later. And all this is in order to be able to initiate primary prevention therapies. There are so many risk calculators out there, and it is quite confusing. And as you, and my introduction, she did talk about our collaboration with the American College of Cardiology. And I, for one, have this ASCVD risk score from the American College of Cardiology, even on my cell phone, and it helps you, and I'll take you through it. But Framingham risk score, again from America, this in the 90s, score CVD risk 4 is from the European Society of Cardiology. JBS 3 score is typically from UK. Then there is a special Reynolds risk score, which was tested out in healthy female adult population. There is a predict CVD risk score from New Zealand. China too has its own risk score. Unfortunately, we do not have a risk score of Indians. And Indians, as I told you, get coronary artery disease as well as strokes a decade earlier than the Western world. Now, one limitation of ASCVD risk score is that it does not account for the family history of premature CVD. It is there as a risk enhancer, but not within the score. And family history of premature coronary artery cardiovascular disease is akin to smoking, as high as smoking, and it puts the siblings of your patients, if your patient's sibling is having premature CVD, then puts her at a 40% risk increase. And if she's an offspring of a parent with premature CVD, the risk goes up to 60 to 75%. The other criticism about ASCVD, it simply tells you yes and no as far as diabetes is concerned. And of course, people who have long-standing diabetes, the risk is actually more, and it doesn't take into account all that, which some other risk scores do. But I think for practical purposes, taking an ASCVD risk score is good. And like I told you, it is available online to you, as also it is available on a mobile app. You simply, this is a mobile app that I'm talking about. It has been updated in 2018, and it's called now ASCVD Plus. And simply by clicking on this, you get this kind of an entry chart to put in right from the gender. All your patients are obviously going to be females. The age, race, ethnicity is also taken into account. Unfortunately, the ethnicity doesn't necessarily talk about Indians as such. And then the total cholesterol, LDL cholesterol, HDL cholesterol, what Dr. Unni was alluding to, whether the patient is on treatment with statins, systolic blood pressure, hypertension, and so on and so forth. So once you have done that, you would then, now this is the algorithmic approach now that we take. I told you about the algorithmic approach. This is applicable to all patients from 20 to 70 years age group. So check the lipid profile once you have looked at the traditional risk factors. If the LDL is very high, for instance, 190 in the Western world, I would put that as, from practical perspective, more than 160, the bad cholesterol. Straight away, you will prescribe aggressive lifestyle change along with statins. Or if it is not so, then you may look at the risk-based age-based assessment. And that is so for the age group 20 to 39, it has to be informal, because you will have to, it considers these people, why do we call it informal? It considers this age group people as being 40 to 70 years, because all studies are in this age group for formal estimation of the 10-year risk score. And the formal estimation wise, you can divide your patients into these 4 categories based on their 10% event rate. Less than 5%, 5 to 7.4%, 7.5 to 19.9%, and high risk is more than 20%. It is the borderline and the intermediate risk score where we are not on what you call shaky ground, or cannot really prescribe preventative therapies directly. Healthy lifestyles, yes, but for them you might want to look at, which this risk calculator also gives, a 30-year risk score, lifetime CVD risk score, which if it is more than 40%, straight away you prescribe and initiate. Otherwise, in this group, you initiate discussion about what prevention strategy you're going to follow. And this we have talked about already. So for our patient, if you have keyed in, she is 41 years of age. She is other as far as the risk ethnicity is concerned, other risk, neither she is black nor white. She has got an LDL cholesterol of 112, total cholesterol 198, a low HDL cholesterol. She is like Dr. Unni talked about. She has the typical metabolic syndrome with obesity and high waist hip ratios. She is not on a treatment with statin, but her blood pressure is fine. She's not on any treatment. Thankfully, she is not a smoker. And what do we do for her? You straight away get the risk in her as being a low risk. But you look at her lifetime ASCVD risk, she's 39%, approaching 40%. You should definitely initiate discussion with this lady and about whether to give statin or not, which because she is just there at 41 years, and though she is on the lower side of the 40 to 70 age group, you click on the advice and you will come across as to what advice to give her in terms of her LDL cholesterol management. You have to prescribe her as a class 1 level of evidence A recommendation, a moderate intensity statin, and a high intensity statin will be, maybe you may also think about high intensity statin. So it's time for you to become what you call cardiologists, the gyno, whatever you want to call them, as not a diabetocardiologist or a PCOS cardiologist is what you should become, is my humble plea. So today after the lecture, please do download some kind of a risk calculator. And for her lifestyle, there you say that somebody was asking about smoking, quit the butt is definitely there. But these three things which we assess, that is HDL is the good cholesterol, so H for hypertension, D for diabetes, and L for lipids. To assess her ASCVD risk, we have to then reclassify if she is in the intermediate risk and resort to coronary artery calcium scoring as required. As far as physical activity and healthy diet lifestyle is concerned, it is there. 30 minutes of brisk walking 5 days a week is good enough to reduce the cardiovascular risk, that is to say. Of course, needless to say, this patient has to get onto a obesity reduction. About diabetes, you are already aware of, thanks to PCOS, about metformin therapy. But after that, as a secondary therapy, these are wonder drugs today, SGLT2 inhibitors, and she could become a candidate, especially if there is established for a diabetes management, even by all guidelines, and definitely so if there is an established CVD occurrence in any one of your PCOS patients. So besides that, like I told you, the greatest limitation, family history of premature ASCVD, was not there in the risk calculator. But to enhance the clinician and patient risk discussion, we have what is called as risk enhancing factors. And there is a list of all these which you should be aware of, like family history of premature ASCVD, which I have alluded to, or primary hypercholesterolemia and levels more than 160 to 160 also, you should initiate discussion for sure. The metabolic syndrome, Dr. Unni has spoken about. Again, chronic kidney disease, especially diabetic kidney disease, and some amount of albuminuria coming up or eGFRs going down. Chronic inflammatory conditions are important. So also in your context, history of a premature menopause. So as also patients with preeclampsia in the past, and the high risk ethnicities already coming into the ASCVD risk calculator, that is the South Asian ancestry. Then other biomarkers that we hear so much about elevated C-reactive protein in this during this COVID pandemic. We'll talk about that, elevated LP(a) and others like ankle brachial index and elevated ApoB levels. Now, C-reactive protein, as Dr. Unni mentioned, is a marker of inflammation. So you have to rule out inflammation before you order it in any patient. And what we order is a high sensitivity C-reactive protein, not the usual one. At the lower end of the spectrum, we try to detect with a high sensitivity C-reactive protein. And it has been a known predictor of cardiovascular disease, as is shown by this study, which Dr. Unni has mentioned about, is commonly elevated in women with PCOS. However, there is no consensus on when to get tested about this. The AHA recommends in the intermediate risk group patients doing a HSCRP, and if your HSCRP is more than 3, then it becomes a risk enhancer, as was also shown for PCOS patient in this particular study, which showed that PCOS people compared to the controls had higher levels of C-reactive proteins. So also dyslipidemia, in a meta-analysis, it was shown that the LDL levels as well as lower HDL levels were seen in PCOS patients. The LDL levels were 26 milligram higher, and the triglycerides were 12 milligram higher. That was there in this Korean study. Then lipoprotein A has been identified as an independent risk factor. However, only person who gains by ordering LP little a is probably the path lab people. May use it as a risk enhancer, but there are no targeted therapies, and we do not get after LP little a, though there is so much literature on it in our scenario. The coronary artery calcification has been found to be more prevalent, is what we have mentioned. So also the metabolic syndrome, BMI, waist circumference, height, bad cholesterols are all associated with coronary artery calcification, as was shown in this study here. So as far as coronary artery calcium scoring, we recommend it for the intermediate predicted risk people or the borderline, the middle group, where the borderline predicted risk people. We do recommend doing a coronary artery calcium measurement, which is a useful tool, and we can decide about whether this group gets onto statin therapy. For instance, this particular patient, it could be a candidate for doing a coronary artery calcium measurement, but based on her diabetes and her other parameters, even the ASCVD risk classification itself tells us that she is a candidate for statin therapy. Now, importantly, in the middle group, you can decide if the coronary artery calcium score is more than or equal to 100, straight away her risk goes upwards. Or if it is downward, if it is 0, for instance, then she gets into a lower caste, becomes low. She's already low by the calculator, but this is important. How do they do it? How do they classify it? 0, no identifiable disease with a CSC score of 0. 1 to 99 is mild. 100 to 399 is moderate, which all translates into the same kind of risk score that we talked about. And 400, more than 400 is severe. So however, it is not intended as a screening for all your ladies, neither for any other general population or for PCOS patient as of now. And then what is the implication of a CAC risk score of 0, especially in our practice, patients who are reluctant to initiate statin therapy, or if they have, or if we want to reinstitute statin therapy because of statin associated side symptoms, you have stopped it, say. Now, typically doctor patients do that. We do not want to take statins because they are the ones who have a nocebo effect and start complaining of muscle symptoms. So if you want to reinstitute statin therapy, simply order a CSC. And if the CSC is on the higher side, that gives incentive enough for the doctor patient also to get started on it. And there are other scenarios, especially the middle-aged adults in the middle-aged group, where your calculated risk score is in the 5 to 7.5% risk, which increases your risk if they are in the borderline risk. And if they have a CSC score, risk enhancer, they straight away go into the high risk. Coronary angiography remains the gold standard, but a word of caution here, just because your calcium score was high, don't, some disease here and there, people land up ordering coronary angiogram. There is a separate set of indications for coronary angiography, and if somebody is ordered a coronary angiography, then it defeats the purpose. We cannot get coronary angiography done for all, and that is not the way to go. However, on the basis of coronary angiographic studies, the standard PCOS things about patients having hirsutism, lower levels of HDL or higher concentrations of TG are all associations that have been described. So finally, the take-home message here is that although patients with PCOS are at higher risk of ASCVD compared to the general population, as was pointed out so well by my previous speaker also, there are no specific guidelines or scoring systems, or our existing scoring system do not put PCOS yet as a risk enhancer, if not as a part of the risk calculated traditional risk factor. Having said that, the treating gynecologist, all of you people should be aware and be vigilant about the cardiovascular risk while treating your PCOS patients, and be ready at least to take primary preventive measures. It's all about primary prevention when such patients present to you. Detailed studies for risk stratifications are necessary in this patient population, not only our part of the world, not only all over the world. This is absolutely necessary because it adds to the fact that Indians and Indian ethnicity PCOS are probably at higher risk. And you should be able to, in the panel discussion, tell us whether you really have seen lots of coronary artery disease in your patient population. Thank you for your attention.
Thank you, Professor Kerkar. That was indeed very well covered, and we probably cannot take over as lady cardiologists, but we definitely could look forward to be a link between those patients who are likely to have cardiovascular disease and have a better vigilance in our clinics when we are looking at young girls and young women who come to us with so many different kind of symptoms. And yes, we will take the questions and the discussion a little later after we have heard Dr. Jyotsna Madhuri, and I would like to welcome Dr. Jyotsna Madhuri, who is heading the Department of Cardiology at the Nizam's Institute of Medical Sciences at Hyderabad, and she has been awarded the Women Leadership Award 2020 by the HIBIS TV Women's Leadership Award and in the Cyber Convention at Hyderabad, and also the Best Women Researcher Award of 2019 in Chennai. Her areas of interest being interventional cardiology, women-related heart diseases, and cardiovascular research. Ma'am, we welcome you to this workshop, and you can proceed with your talk. Thank you.
Hello, thank you very much, Gauri, for the nice introduction. And I'm really delighted and so nice platform of the PCOS organization along with this CSI collaboration. And it is really the first meeting of this kind I'm attending. But actually, the WINCARS, the Women in Cardiology and the Related Sciences, we recognize the importance of the Cardio Gynops Association as a separate branch of the cardiology. And we started these in the WINCARS in 2015 with the incorporation of the nearly the 25 gynecologists and obstetricians in our association. So in my presentation, I wanted to give a little bit importance to the risk factors which are specific to the female, because mainly I concentrate on the how the females differs from the men. Hello, welcome to all the delegates. Today my presentation is about the prevention of the CVD in women. At this juncture, I wanted to give a brief introduction about the inequality of the treatment management and the presentation of a CVD in the woman, because this is the exact correct forum where the women gynecologist has to take care of cardiovascular diseases. As you already know, the cardiogynec branch becoming a much more than important, and the gynecologist has to pay attention whoever the woman or the lady comes to them with the gynecological problems to tell about the CVD risk and requires an evaluation. Second component, I want to concentrate on the risk factors specific to the woman so that we can concentrate on the what type of the preventions we can advise to them. And finally, I will tell about the latest guidelines of this year of ESI for the cardiovascular disease prevention in the clinical practice. Coming to the CVD is the leading cause of the woman death, and the diagnosis of the acute coronary syndrome is often challenging in the woman. Women are less likely to receive a preventive treatment or guidance, such as a lipid-lowering therapy, aspirin, or a therapeutic lifestyle changes than in the men who have the similar cardiovascular disease severity. When the medications are prescribed, treatment is less likely to be aggressive or to achieve optimal effects. For example, when a hypertensive female is given the blood pressure goals never reached, and hyperlipidemic women, especially with the coexisting diabetes, they don't take an effective dose of the statins to decrease to the therapeutic levels of the LDL. So also cardiac rehabilitation. Nearly the 55% less likely to participate in cardiac rehabilitation programs by the women when compared to that of the men. The important world study, that is the Women's ischemia syndrome evaluation wise study has demonstrated that not only in obstructive coronary artery disease, there is some specific features of a coronary artery disease in a female. That is, they will have normal coronaries, but abnormal coronary reactivity, microvascular dysfunction, plaque erosion, distal embolization are the major specific female specific IHD pathophysiologies. And women with an IHD have a persistent suboptimal treatment patterns, higher mortality, and poorer CVD outcomes compared to that of the men. The sex difference may be mainly because of sex hormones, which may cause a unique gene expression and the function. The results in the variation in the prevalence and presentation of cardiovascular conditions, including those associated with autonomic regulation, hypertension, diabetes, vascular, and the cardiac remodeling, are the different in the females when compared to the men. Coming to the traditional risk factors, which are the common for the both male and females, are the diabetes, smoking, obesity, overweight, physical inactivity, hypertension, dyslipidemia. Subsequently, I will tell what is the difference between the men and women in these traditional risk factors are also. Which are emerging and non-traditional specific to the females, the risk factors are preterm delivery, hypertensive disorders of pregnancy, gestational diabetes, autoimmune disorders, breast cancer treatment, and depression. Even in the diabetes, even though it's a strong risk factors for the both men and women have threefold increased risk of the CAD development and a higher mortality with an MI and higher incidence than a heart failure. And diabetes is a stronger risk factor for the stroke as well as to the PVD. So the recommendations are that both men and women with diabetes should have a proper management for the cardiovascular risk reduction. And hypertension is much more prevalent in the females than in the men after the age of 60, and simultaneously the less well controlled. So we have to encourage the optimal BP goal to reach, that is 140/90, with an exercise and the drug therapy in the woman. And the dyslipidemia, which is much more prevalent, about 46% more than in the men. So effective secondary CVD prevention by the statin therapy has to be insisted on them. But one of the good feature is atheroma regression, and LDL lowering is much more effective in the women with the statin therapy than in the men. So that has to be used by then all the general physicians also to have a good effect on the control of the dyslipidemia. Obesity is also incidence is more in the women, nearly 64%. That's why the degree of the exercise is advised is more than the men. That is nearly minimum of 60 to 90 minutes of the exercise is required more, and almost every day. Usually, most of the times it is told as 5 days a week. But for a woman, because of this, especially obese, is indicated to do every day. Physical inactivity is also higher in the women. So they advise at least a minimum of 75 minutes per week of the minimum exercise to come out of this physical activity. Of course, smoking, this is not proved effective in a 30 to 40-year-old females, but above the 45 years, the even passive smoking prevention is decreases the additional risk factors, and which are is near pregnancy is not only during the pregnancy, it is a risk factor for the mother survival, but for the subsequent IHD, even after the 12 years, there is increased risk. There is 16-fold relative risk for the IHD at 12 years, and 81-fold risk for stroke after 10 years, and 79-fold relative risk for venous thromboembolism for the next 5 years. Of course, gestational diabetes, even though it is a transient one, but it is associated with the 2 to 4-fold incidence of the MI in the females. Another major problem after the pregnancy is the persistence of the weight gain, and nearly a 20% of increase in the weight gain then occurs. And after the delivery, because of the increased workload, they have the less time to then exercise. To cause this weight reduction is also becomes very difficult for these females. Weight at the 1 year postpartum is a stronger predictor of the likelihood of overweight for the next 15 years, which is a strong traditional risk factor. Autoimmune disorders are the much more frequent in the females, especially rheumatoid arthritis and the systemic lupus erythematosus. These are causes about 2 to 4-fold higher than MI and 50% higher risk for the stroke. Not only the disease itself, if the treatment of the disease with an immunosuppressive drugs are also predisposed to this condition. Another important therapy is the radiation and the breast cancer. This increase in the proportion mean dose of the heart of the radiation causes the continuing risk to the cardiovascular risk for the next 20 years. So the rate of the CVD events increased by 7.4% per 1 gray of the mean radiation dose delivered. The survival of the breast cancer is enormously increased. That is very, very good. But it is at the cost of increased acute, subacute, and the late cardiotoxicity due to the chemotherapy. So the chemotherapy complications are classified as a type 1 if the anthracycline like in agents producing cardiotoxicity, or a type 2 is the tocilizumab like in agents producing it. So these people, next 5 to 10 years, it is recommended in the high-risk patients to have a functional, non-invasive stress testing for the occurrence of the cardiovascular diseases. Depression is also an important risk factors for the females, and the very few people will have an younger age group, but then as the age increases, especially by the age of the 50 years, nearly the 40% will suffer. Previously, premenopausal state was considered as a protective mechanism, but subsequently it was then felt that because of increased diabetes, that the protective effect is gone. And but after the menopause, there is an increased incidence, mainly because of these ovarian steroid hormones, especially estrogens, which protective effect is gone. They becomes more predisposed for the CVD. But the trials, WHI and HERS trials had definitely demonstrated that the estrogen supplementation is not going to decrease the incidence of the coronary artery disease in the postmenopausal condition. The major thing we have to concentrate on the prevention of the CVD, mainly the goals we have to keep, what we have to prevent it. So apparently healthy person's 10-year cardiovascular risk has to be calculated. If already has an atherosclerotic coronary artery disease, then we have to calculate the residual coronary vascular disease risk into the specific conditions like the CKD, familial hypercholesterolemia, obesity, diabetics. So first we have to risk stratify them, and then depending upon that, we have to tell to them personalized treatment. Because we say that lifestyle modification is required, psychological factors, psychosocial factors has to be controlled, risk factors to be then treated like a smoking cessation, lipid strain has to be controlled, blood pressure has to be controlled, diabetes has to be under control, antithrombotic therapy is decreased, disease-specific interventions required. If you say the list of the things to a patient, it may not be implement anything to them. If you do the personalized decisions for them, like if they have the rheumatoid arthritis, for the physical activity, you have to suggest the modifications. So also the psychosocial factors. If it is in a workplace, the abnormalities, then we have to then advise and take a psychiatrist advice to do that. And so also the smoking cessation, the people who are working in this factories, to smoking cessation becomes a difficult, and how they can change the jobs. So personalized treatment, the decisions, if you're given, that way is going to be much more helpful to them. So once you categorize them into the different categories with the disease, without disease, with type 2 diabetes, or with the familial hypercholesterolemia or dyslipidemic syndromes, then in the 2 steps we have to the control. Directly going for the higher control may be the difficult for them. In the first step, the goals has to be then achieved, like as I already mentioned, the weight reduction, the blood pressure control, the diabetes control, and lipid control should be there. 70 LDL control should be there, 70 milligram per deciliter, which has to be increased in the step 2 to the 55 milligram per deciliter. So calculation of the CVD risk at 1 year is not sufficient. Every 1 year we have to reassess whether the cardiovascular risk is going to be changed or not. Then ultimate preventive goals has to be decided on that. According to the 2016 ESC prevention goals, the SCORE and the SCORE 2, that is modified one, and SCORE 2 OP algorithms are mainly used to classify This risk, thus risk is classified as less than the 2.5% of them having a chance of developing a CVD, or 2.5 to 7.5, or more than 7.5. So it is who is less than the 50 years with an estimated risk is less than the 2.5. There is no additional prevent and risk considered risk modifications, and but no additional preventive goals are required. But the same thing is not applicable when the risk is more than 7.5. Then we have to insist on the blood pressure, the levels of less than 140, if possible is less than 130. And even the drug therapies also has to be the 100 milligrams of the LDL controlling statin group will be sufficient. But as the age increases, as the severity of the risk of the developing increases from the 7.5 to the 15, that additional drug therapies are also is indicated, like in this case, dual antiplatelet drugs and DPIs and novel upcoming interventions like EPA, colchicine are also has to be considered in them. So the intensification of the treatment is mainly depending upon the reassessment of the residual cardiovascular risk for the 10 years and the lifetime CVD risk and the treatment benefits and the comorbidities, fragility, and the patient preferences. So the major thing when the stop smoking and the lifestyle recommendations are the class 1 for all the group of the patients, and the HbA1c has to be the less than the 7% in the diabetic in patients. And if there is no the associated cardiovascular disease, then the moderate restriction of the preventive measures will be the do it. But if there is a high risk of the development, then a much more appropriate control of the systolic blood pressure and as well as an LDL is required for them. And nowadays, SGLT2 inhibitors and GLP-1 drugs are the much more indicated even for the prevention of the disease, even in the non-diabetic conditions. Of course, as I already mentioned, there are the few of the traditional upcoming therapies are the required when the risk factors are then very high. So coming to the patients, especially with the associated with the CKD, then much more control of the cholesterol, the systolic blood pressure is required. So also cases within familial hypertriglyceridemias, and in the diabetes, the stop smoking and the lifestyle optimization and the HbA1c levels has to be the less than 7. So if we go for the primary prevention guidelines, early screening and the complete CVD risk assessment are associated with a reduced CVD risk in the woman. So this is an ideal time when the patient comes with the gynecological problems, it doesn't have the risk factors. This is an ideal time to tell about the primary prevention. And especially nurse health author studies highlighted this, and which decrease the mortality in the females. And what are the parameters that reduce the risk of the coronary events according to the studies? Not smoking, and maintain a healthy body weight, and consumption of the healthy diet, and participating in the moderate and the rigorous exercises, and consumption of the alcohol has to be restricted. The intra-heart study has mainly told about the 9 measure the risk factors like smoking, lipids, hypertension, diabetes, obesity, diet, physical activity, alcohol consumption, and psychological factors. This study is very important for us because this is done in an Asian population. What is meant by the really the healthy diet? Adopt more of the plant and the animal diet. Saturated fat should be less than 10%, and less than 5 grams of the total salt intake should be there for the day, and 30 to 45 grams of the fiber should be there, and more than 200 grams means 2 to 3 servings of the fruits per day should be there, and red meat should be the reduced, and fish is recommended 1 to 2 times a week, and 30 grams of unsalted nuts. Nuts should be unsalted per day, and consumption of corn should be restricted to the less than the 100 grams, and sweeteners and all those are not indicated. ASA, as in the men, it is not that much productive for the female, especially for the stroke reduction is not there. So, under the ACC/AHA guidelines, low dose is recommended for the females when the CVD risk is more than 10%. If the low risk people, where the bleeding risk is also high, ASA is not recommended. So coming to the drug treatment of the hypertension, as we already know, the initial therapy with an ACR, ARB, with calcium channel blockers and diuretics is now considered as the first line of the therapy. When there is no improvement, then a triple combination. That is, we can add the spironolactones, and in the third step, triple combinations can be used. But our main aim is to achieve a BP equals of less than 140/90. So the major therapy is the class 1. The recommendation is the CCBs, diuretics, and RAS blockers, RAS inhibitors are the considered. Now the beta blockers are not considered as a class 1 indication drugs for the hypertension control. And recommendation of treatment patients diabetes is the lifestyle changes is the class 1, and a reduction in the energy intake is recommended to the patient. Lower body weight and prevent a slow weight gain is a class 1 recommendation. And of course, as I already mentioned, HbA1c should be less than 7. That is class 1 indication. And the statins are nearly the 27 trials have demonstrated that the statin treatment in the women is much more effective than in the men. So the LDL goals, that is in the step 1 less than 100, and in the step 2 less than 75 is recommended. That is a class 1 indication, and we can use the statins primarily used. Statin resistant or statin sensitive, we can use the ezetimibe. Even with the ezetimibe, there is no improvement. P6 inhibitors can be recommended, that is a class 1. And the combination of all these drug therapy when the very resistant dyslipidemia is also a class 1 indication. Just I wanted to tell about a few of the new features which are added in these 2021 guidelines for prevention, or apparently healthy 70-year-old age without an established either diabetes or CKD or the coronary artery disease or anything, use the score 2 to risk stratify them, or score 2 to risk stratify, and mainly used to inform about the CVD risk and treatment benefits tailored to the needs of the patient is recommended. They insist on the personal treatment than the giving a general recommendation. And estimation of this risk factor at a one stage is not sufficient. Yearly estimation of the 10-year risk is required. And in women, the history of the premature stillbirth or who has then hypertension during the pregnancy require a periodic checkups at least for the next 10 years for the risk assessment. And in a patient with the diabetes more than 40 years of age with a high risk, then the goal of an LDL should be the less than the 70 years. And the participation in the medically supervised, structured, comprehensive, multidisciplinary approach and preventive programs for the patients within atherosclerotic prevention, even after the revascularization, or patients with heart failure is recommended to improve the patient outcomes, especially the females in the heart failures is much more frequent. So the structured programs for the preventive rehabilitation programs has to be then attended. And the patients with the moderate to severe depression should be considered for the antidepressant treatments. And we have to consider the drug interactions along with that whenever we recommend these recommendations. So I advise all of the females to work hard and decrease the physical inactivity and do the exercise every day, not once not 5 days a week. And treatment goals or the BP should be the less than the 140 if possible, the less than the 130, and the cholesterol LDL especially less than 100 if possible, the less than 70. And annual assessment of the risk is much more important, especially the people who has a bad obstetric history. Thank you all.
Thank you, Dr. Jyotsna, for such an excellent talk on what we can do to prevent CVD in women. As Professor Prafulla Khirka has to leave, we will just address a couple of questions to him, and then we will take other questions. Sir, you did mention about the need for risk assessment for gynecologists as such, we are multitasking. So with reference to the women with PCOS, there are 3 distinct points at which we tend to see these women. One is adolescent period. Second is, with infertility, and third is post-delivery. So how we can utilize these points practically to do risk assessment, cardiovascular wise?
Yes, see, like I mentioned to you, that this risk calculators and all, and risk calculations start after the age of 40 for everybody. And the data is out there from after the age of 40. There is nothing specific in our cardiology groups. I'm sure Dr. Unni will agree with me that PCOS becomes a risk enhancer. But having said that, we know from data that PCOS is an increased risk factor, like a kind of a risk marker definitely for CVD. So at whatever age it be, adolescents also, healthy lifestyles, from at least from the 20s onwards, you get any patient who is suspected to have PCOS, it becomes your duty sort of to try and see as to at least start prescribing healthy lifestyles to this patient. Then just getting into the risk calculator is just like that illustration that I also showed you. It is just that it puts into you that traditional risk factors becomes a part of a checklist of a PCOS. For instance, if you are 20 or 20 something or say 30s patient has a family history which is strong for coronary artery disease, okay, then you would want to initiate discussion with her and with her family that healthy lifestyles have to begin. And if she is the real phenotype, has got a metabolic syndrome and everything, it is, and whatever score that she falls into, intermediate risk or otherwise, you would then go ahead. The app tells you everything. And actually, it makes sense when you are such a big society in yourself and we've got this collaboration going. I think there is nothing big deal about, even general practitioners do it today. They know how to prescribe statins or aspirin. That's as far as the preventive therapies are concerned. And she's already mentioned to you. So at all time frames, I think you are for it.
So at least we start identifying, then we may take, cardiologists' help to initially.
Yes, so cardiologists help even before the cardiologists help. It's for you. It's only for a prescription that you might want to take help of a cardiologist. But otherwise, all these investigations are for you to do. Why do you need to go to a cardiologist?
Okay.
That's what I'm trying to tell you.
One more thing, sir, I was looking through that ASCVD risk calculator. As a gynecologist, we are always, advising our patients, reduce your weight. We check the BMI, we check the waist circumference, but the risk calculator does not mention anything about the BMI or.
Absolutely. So these are the downsides to it. But risk calculator wise, metabolic syndrome is there as a risk enhancer. And if she falls into the borderline or intermediate risk group, then you may do the risk enhancers that I listed out and therefore take measures about it. So it's about preventive therapies. There are 2 therapies, statins and aspirin, and and control of blood pressure and diabetes is understood. And there are healthy lifestyles. So healthy lifestyles will start. Her obesity has to come down. All that has to happen. So that is what it is. It don't require, it's not such a rocket science that a cardiologist is going to do anything different. This is what I'm trying to impose upon you.
We need to start identifying the risk factors. And if pharmacotherapy is required, then I think your guidance would be invaluable for such patients.
Yes. And that pharmacotherapy also, it's prescribing also. See, clearly if that risk goes, as she mentioned, more than 10% if you are using the score risk, or if the risk goes into the intermediate risk, then you can take recourse to this, and you can intermediate risk and the high risk, more than 20% risk for 10-year risk, then she is clearly high risk, definitely requires statins. And that is when you could prescribe, send it across to the cardiologist, is what I'm trying to say.
Okay. Yes, sir. Yeah. I think.
May I leave with your kind permission? I'm sorry, because I have to start a session at 12. Okay.
Thank you so much for being with us today. Thank you so much on behalf of PCOS Society and all of us. Thank you so much, sir.
Thank you. Thank you very much. It was a pleasure. Bye-bye. Dr. Unni and Dr. Jyotsna will look at all what is there directed to me. Thank you so much. Pleasure.
Thank you, sir. Thank you once. Professor Unni, once again, it was a very informative and very educational talk you have given. there are certain points which you mentioned, which we presume that PCOS is associated with high risk of cardiovascular disease. That is where we start thinking about cardiovascular disease, and that is where we stop thinking about cardiovascular disease. But what you said was something very different. Even though PCOS appears to be a very important marker for cardiovascular diseases, the actual event rate is not as high as expected. Is my understanding right from
Yeah, that is actually conflicting evidence. As I said, there are two trials which showed that there is increase in cardiovascular events, but the longest trial, which lasted from 1987 to 2008, gave us quite a different picture, that it is just not increasing. So maybe we should the message that I think we should give is that if you properly control the risk factors at the appropriate time, you can definitely prevent an increased event rate in the post-menopausal period. That is at that time that you get all these problems. So in the earlier age group, if we can control these risk factors, you are safe. I think that should be the message that should go out.
Sir, compared to the obese and lean PCOS, when we compare the two subgroups of PCOS, is one subgroup more likely to have cardiovascular events than the other subgroup? Is it the obesity which is predisposing them to a higher risk, or the PCOS in itself?
Obesity is an
dilemma we have.
Yeah, obesity is an enhancer, though it is not the sole risk factor. So a patient who is a diabetes, hypertension, dyslipidemia without obesity is also at an increased risk. However, if you add obesity, it becomes more. So obesity is important, but it is not the sole criteria. Even lean people have a higher risk factor profile.
So, is it okay to counsel our patients when we are talking about lifestyle modification as part of our counseling for women with infertility or with any other problem, PCOS women presenting to us, to say that the current evidence does suggest that if you do pay attention to all the risk factors, preventive strategies, your risk may get mitigated. Is it?
Yeah,
okay?
Your risk may be as good as somebody who do not have a PCOS, provided you control your risk factors.
Okay. Thank you, sir. Gauri?
Yeah, so that is what I was going to come to, that when Dr. Unni mentioned that even lean PCOs and obese PCOs have a similar risk at one point of time, and making obese women feel that they are at higher risk is probably at the moment the studies are not so evident, saying that that they really make a difference. One more thing in the markers which Dr. Kelkar was mentioning was lipoprotein. Now sometimes when we order, we ask our patients to come with a list of lab tests, and they will come with a big bunch of tests where they will have a lipoprotein also done. And as gynecologists, sometimes we are not sure whether we need to aggressively address this lipoprotein levels. So what would be your recommendation for this?
Yeah, before lipoprotein, let me clarify regarding obesity. Obesity is definitely bad. There is no question about it. Forget about PCOS. Even without PCOS, obesity is a risk factor. So definitely you have to advise your woman, young, old, or even childhood obesity is bad. So reduction of obesity is of prime importance. There is no doubt about that. And reducing obesity with regular exercise not only reduces obesity, but also affects other risk factors. With respect to lipoprotein little a, it is generally believed that lipoprotein is genetically determined. So you cannot modify it. The only drug so far we know which reduces lipoprotein little a is what are known as PCSK9 inhibitors. So lipoprotein A as such, you cannot target as a treatment. But if somebody has a high lipoprotein little a, that tells you that this patient has a higher risk of coronary artery disease, and hence you have to treat other risk factors more aggressively. You have to treat his blood pressure more aggressively, his dyslipidemia more aggressively, and his obesity, his or her obesity more aggressively. So it is more of a marker than a risk factor.
Okay. Jyotsna ma'am, in your presentation, you had mentioned that sometimes there is something which is a microvascular heart disease that is coming up, and patients might not necessarily have plaques, and is it likely that patients who are having PCO and adverse pregnancy outcomes are more likely to have this microvascular heart disease more than a regular coronary heart disease with plaques and things like that?
Actually, the major difference between the men and women cardiovascular disease is the obstructive coronary artery disease. Obstructive coronary artery disease is much more frequent in the men than compared to the women. It is whether the PCOS is present or not, it doesn't make the difference. But the major thing is in the females, normally patent coronary arteries and the patient is having a classical angina is a common. So the major explanation for those type of the cases is a microvascular dysfunction, which can happen in the men also, but the incidence is at least 4 to 5 times more than in the men. And all the risk factors which I mentioned specific to the female are associated with a much more microvascular dysfunction than in a female without having it. But I have not come across a study which is specifically mentioned that PCOS is associated. But all the traditional risk, what are the non-traditional risk factors I mentioned for the females, that is a premature delivery associated with hypertension, gestational diabetes, yes, associated with a more microvascular dysfunction.
Dr. Padma?
Yeah. Again, Dr. Jyotsna, it was excellent, the concept of preventive gynae cardiology, that concept which you mentioned, where gynecologists and cardiologists work together to achieve this prevention. It is very excellent, and it was very good to hear your involvement and experience in that, and we hope to learn more about that. So considering all the three speakers who have highlighted the importance of an attempt to a concentrated attempt to prevent cardiovascular disease in women, and more so in women with PCOS. When we talk of preventive gynecology, we usually think of breast screening and screening for carcinoma of cervix. We do not think of systemic conditions. So is it time that there are some consensus or guidelines drawn for gynecologists to look at these cardiovascular and maybe diabetes prevention strategies in women? Because women do come to us with whatever problem, whether it is related to gynecology or not. We seem to be their first point of contact. So it is important that we have some set of consensus or guidelines which will help majority of them to benefit from these consultations and not skip through the net.
Yeah, I'm very glad to hear this question so that I can have a better explanations which can be given by a complete gender specific journal. There is the Indian Journal of Cardiovascular Disease in Women, and especially the last year, there is specifically a special issue was brought on the pregnancy-related cardiovascular diseases and what is the degree of the risk factor the development subsequently. And most of these review articles in this journal, which is the WINCAR's official journal for the WINCAR, concentrates on the different aspects of the women which are likely to be required for the follow-up, especially for the gynops. We have in every issue, we have a separate topic on the gynae-related cardiovascular manifestation subsequently. So definitely I advise you to subscribe that, and it is a free of cost, and it is online, it is available. Definitely please go through that. That is one suggestion I can give it. And the second one is about the gynecologist involvement and asking them to go to the cardiologist for the further evaluation is a mandatory. It starts when the age of the 20 years is not at the age of the 40 years. The major problem is, as we already know, the bad obstetric history itself is an indication for the cardiac evaluation. Who has the limited the risk factors, like only single diabetes, is that itself is predisposed from the protective age group of the premenopausal, postmenopausal to the premenopausal. All these age groups requires an attention of a gynecologist to be evaluated and appropriately to refer to the cardiologist. So this association of the gynecologist and the cardiologist, especially for the prevention of the cardiovascular diseases, is very, very important.
Thank you, ma'am. We need to close this session. So I would like to thank on behalf of both of us, all the speakers for delivering such excellent and informative talks. And thank you, Madhuri and Durusha ma'am and the entire PCOS Society team for having us here today and making us learn ever more than before. Thank you.
Thank you, everyone.
Thank you very much.
Thank you all.
Thank you, Padma Rekha and Gauri, for moderating the session. And I think all the three speakers were excellent, Dr. Govindan Unni, Prafulla, and Jyotsna. And now we move on to the next session, which is on management of cardiovascular diseases. And I invite the moderators for this session, Dr. Pia Balani Thakkar, who is the founder member and honorary secretary of the PCOS Society of India. She's a consultant physician and endocrinologist. She is affiliated to Bombay Hospital and Medical Research Center, and she has a clinic at Kulaba. She has several awards to her credit, and one of them being the America's Top Physician by the Consumer Research Council of America. She also has won several other awards and has publications to her credit. Her area of interest is women's health, gynec endocrinology, diabetes, and thyroid issues. We also have Dr. Ashutosh Haldar. Next slide. He is the professor and head at All India Institute of Medical Sciences, Delhi, in the Department of Reproductive Biology. He has won Dr. Subhash Mukherjee Memorial Award in 2019 from the Endocrine Society of India. He also has other awards to his name, and his areas of interest are reproductive endocrinology, genetics, and medicine. I now request the moderators to take the session forward.
Good afternoon.
Good afternoon. Go ahead.
As per our discussion with Dr. Thakkar, should I start or do you like
Please,
to?
sir. Please, sir. The podium is yours, sir.
Okay, thank you. So good afternoon, everyone. First, I'd like to express my thanks to PCOS Society of India for giving me opportunity to moderate this session along with Dr. Thakkar. And the session is on management of cardiovascular disease in PCOS. I also welcome to all virtually connected colleagues and students with this session and request to post your queries in the chat box. Also, you can ask probably live at the end of the session. Questions and clarifications will be answered at the end of the final presentation. The session has three well-known super specialists, cardiologists and neurologists, as speakers on management of thromboembolism, coronary syndrome, and stroke in PCOS cases. So first speaker of this session is Professor C.P. Karunadas. He is Professor of Cardiology, Government Medical College, Thrissur, Kerala. And he has award as an honorary secretary in CSI Kerala, teaching experience of 21 years, publication in international journals, and area of interest in preventive cardiology and coronary intervention. So, recorded presentation will be presented. I now
Respected
invite
Chairperson,
Dr.
senior
Karunadas.
members of the faculty and friends. At the outset, let me thank the organizers of this meeting, as well as Dr. P.P. Mohanan, the National President of CSI, for giving me an opportunity to discuss this very important topic, management of acute venous thromboembolism. As you are aware, deep vein thrombosis and pulmonary embolism is a continuous spectrum. A clot formed in one of the veins of the limbs may remain there asymptomatic, may cause pain and swelling of that limb and even lead to ischemia of that limb. Sometimes it may migrate from there, as you can see on the slide, and go to the pulmonary circulation and produce the disastrous complication of pulmonary embolism. So this is a continuous spectrum. I will start from the upper end, or the most dreaded complication, pulmonary embolism. Whenever we suspect pulmonary embolism, Say the patient has come with tachypnea, dyspnea, unexplained cough, hemoptysis, BP fall, or shock stage. We have to have a pre-test probability of the happening of pulmonary embolism. Why this is important? Because no diagnostic test is perfectly accurate in the field of venous thromboembolism. There can be true positives, true negatives, false positives, false negatives. Actually, a pretest probability plus the diagnostic test accuracy gives you a good post-test probability of VT. There are various algorithms for calculating the pretest probability, difficult to remember by the clinicians. So the European Society of Cardiology has revised and simplified the Geneva score. I'll quickly take you through that. Age more than 65 years gets 1 point. Previous deep vein thrombosis or pulmonary embolism, active cancer, surgery for fracture within 1 month, unilateral lower limb pain, pain on the lower limb on deep venous palpation and unilateral edema, hemoptysis, heart rate between 75 to 94, all of them get 1 point each, while heart rate more than 95 gets 2 points. So if you have a score of 0 to 1, you have a low probability of pulmonary embolism. On the other hand, if you have a score of 2 to 4, the probability is intermediate. And if the score is 5 or more, it is a very high probability. Now let us look at a diagnostic algorithm of pulmonary embolism without hemodynamic instability. First of all, as already said, you assess the clinical probability either by your clinical judgment or by a scoring system like the one shown. If the person has a low or intermediate probability, you do a D-dimer. If it is negative, you rule out pulmonary embolism, and if it is positive, you send the patient for a CT pulmonary angiogram, which may show pulmonary embolism, may not show pulmonary embolism. If the person has a high probability of having pulmonary embolism, you skip the D-dimer, go directly to CTPA, which rules in or rules out a pulmonary embolism. On the other hand, if the person is hemodynamically unstable, you don't have time for all this. You get a bedside echocardiogram, see whether there is RV dysfunction. Yes, if you can get a CTPA done, do it. If not, treat it as a high-risk pulmonary embolism. If there is no RV dysfunction on bedside echo, search for other causes of shock or instability. And how are we going to manage a case of pulmonary embolism? Well, anticoagulation should be done for all patients. It's a must. Then you see whether the patient is hemodynamically unstable. Yes, if your answer is yes, that is a high-risk situation. That patient requires reperfusion treatment along with hemodynamic support. On the other hand, if the patient is hemodynamically stable, you have to categorize them into a low risk or a high risk pulmonary embolism. If it is an intermediate risk group, we can do a troponin test, and if it is positive, consider RV dysfunction. These patients require monitoring and consider rescue reperfusion if there is deterioration. If troponin is negative, they require hospitalization. On the other hand, if there is no RV dysfunction or nothing on the CTPA, it's a low risk group. And if the person doesn't require hospitalization for any other reason, he can have an early discharge and home treatment. So what are the various modalities of treatment available for pulmonary embolism? One is anticoagulation. It's a must for all patients. Thrombolysis is there. Surgical or catheter-based intervention can be done. Supportive measures in the form of fluids, pressor agents, or ECMO, as well as IVC filters, along with graduated compression of legs, are the various forms of treatment. Anticoagulation can be done with low molecular weight heparin or fondaparinol, which is preferred over unfractionated heparin. If we are using oral anticoagulants, NOACs are preferred, or vitamin K antagonists. I need not discuss the dose of unfractionated heparin. You can give a bolus 80 followed by an infusion of 18 units per kilogram per hour, which roughly converts to 5,000 unit bolus followed by 1,000 units hourly infusion to keep the APTT 1.5 to 2 times the control. If it's a low molecular weight heparin, you can use 1 milligram per kilogram BD of enoxaparin or 1.5 milligram per kilogram once daily of enoxaparin. If we are using vitamin K antagonists as the oral anticoagulants, you have to start them immediately along with heparin or low molecular weight heparin. Titrate up the dose to make the INR 2 to 3, and heparin or low molecular weight heparin has to be continued for at least 5 days. If you are using Novax, there is no need for heparin bridging. Only thing, you have to calculate the creatinine clearance. Thrombolysis is required if there is hemodynamic instability. Streptokinase can be given 2.5 lakh bolus followed by 1 lakh hourly infusion for 24 hours. Next is the role of IVC filters. Well, the European Society says it can be considered in patients with acute pulmonary embolism who have absolute contraindication to anticoagulation, or they have recurrent pulmonary embolism despite therapeutic anticoagulation. So far, I have been discussing in general about the management of pulmonary embolism, which may not be very useful to each and every one of you, because once a patient develops pulmonary embolism, the management is taken over by the team of cardiologists, intensivists, gynecologists, and all. So let us have a discussion on a case scenario, a case of DVT in pregnancy, to exemplify the factors I have already mentioned. A 32-year-old lady, first pregnancy with 28 weeks gestational age, with no significant past history and using only prenatal vitamin tablets, has now come with swollen and painful left thigh for 48 hours without any chest pain or dyspnea. Which investigation will you do? Just keep in your mind, which investigation will you do? One can do a proximal compression ultrasound over the left lower extremity, which was done in this lady, which showed no evidence of DVT in the popliteal, femoral, common femoral, or external iliac veins. What next? You know that there is a possibility of deep vein thrombosis here. Which one will you choose here? Let us take D-dimer. D-dimer has limited utility in the following patient groups, especially in a patient who is pregnant, hospitalized, or post-surgical, so not of much use to us. What about ventilation lung scan? Whatever be the investigation involving radiation, there is a risk of radiation to the fetus, there is a risk of radiation to the mother. The various doses exposed are given in the table here. So it is better avoided. So the next choice is do a serial ultrasound. Repeat the ultrasound after a few days, because one ultrasound alone has got limited sensitivity for pelvic or iliac DVT, which is the most common site in pregnancy. It has been shown that single ultrasound may miss up to 24% of DVTs, and repeating the ultrasound within 5 to 7 days lowers the rate of missing. What about MR venogram, which was one of the choices given there? It detects pelvic DVT better than an ultrasound, not associated with fetal harm. Only problem is the availability issue. So in this patient, a serial compression ultrasound of the lower extremity was chosen, and after 5 days it was done, which showed thrombus in the left common femoral vein. She was ambulatory, she had some pain, but well controlled with acetaminophen. And if you look at her vital parameters and oxygen saturation, they were normal. The left leg was warm with normal pulses and normal sensation. The next question that comes here is, does this patient require admission? Not necessarily. OP treatment is appropriate in a low-risk patient. But if the patient has any high-risk features as shown here, abnormal vital signs, severe analgesic needs, extensive venous thromboembolism, advanced gestational age, comorbidities, contraindications to low molecular weight heparin, or lack of home support, it's better to admit them. So this patient requires anticoagulant therapy. Again, I am giving you 4 choices. Which one will you use? Direct oral anticoagulants are out. They are not to be used in pregnancy. Subcutaneous unfractionated heparin can be used, or low molecular weight heparin can be used. The recommendation is to use low molecular weight heparin once or twice daily without anti-10A monitoring. Both low molecular weight heparin as well as unfractionated heparin are safe in pregnancy. Fonda is not preferred. Vitamin K antagonists again are not preferred. How do you dose the low molecular weight heparin? Should you give twice daily? The compliance will be less. It's difficult for the patient to take 2 times a day or once daily. Both the regimes have been tried and there is no much of difference between these 2 regimes. There is no need for routine monitoring of factor 10A levels in pregnancy. Is there any role for catheter-directed thrombolysis into the leg? Only if there is a limb-threatening ischemia, it has to be done. So let us continue with the case. She was given anticoagulation with low molecular weight heparin, and in 2 weeks, her leg swelling and pain improved. Low molecular weight heparin was continued. Now she is 35 weeks of gestational age and prefers a vaginal delivery with epidural anesthesia. That is a problem now. Whenever you are going to insert an epidural catheter, low molecular weight heparin has to be stopped. So it's better to have a scheduled induction if you are planning an epidural anesthesia. Stop the low molecular weight heparin 24 hours prior to the anesthesia. Restart at least 6 hours later or once hemostasis is attained, and continue 6 weeks postpartum. So now there is the question of continuing anticoagulation during breastfeeding. We can either use low molecular weight heparin, unfractionated heparin, or vitamin K antagonists. Any one of them can be used, preferably a low molecular weight heparin. She may also ask you about the question of next pregnancy. Do I require an antepartum prophylaxis and postpartum prophylaxis? Well, the answer is yes. The risk of recurrent venous thromboembolism is high in the next pregnancy. Without prophylaxis, it is around 4.2%, and with prophylaxis, only 0.9%. So you have to advise the patient that she will require prophylaxis in the next pregnancy. That finishes that case, and let us have a look at some other aspects. What about prophylactic anticoagulation in a patient who is not having venous thromboembolism? A pregnant woman with no personal history of venous thromboembolism. Still, if there is a strong family history of venous thromboembolism or underlying thrombophilia or underlying coagulation problems, it is better to give prophylaxis. Half dose of low molecular weight heparin can be used than the standard treatment. So if a patient has evidence of thromboembolism, you have to use the full dose. As prophylactic, you use half dose. If the person is opting for a normal vaginal delivery, there is no problem. You can allow normal vaginal delivery on half dose of low molecular weight heparin. But here also, if you are planning epidural anesthesia, it's better to stop 24 hours prior to that. Sometimes we find varicose veins with superficial vein thrombosis, no deep vein thrombosis. Still, it is recommended that anticoagulation be given to prevent this from extending into the deep veins. What about gynec surgeries for malignancy? There comes the issue of DVT prophylaxis. Both pharmacologic and mechanical prophylaxis have been advised. Low molecular weight heparin is preferred, and it is better to give up to 4 weeks after surgery. Well, even though my topic doesn't touch upon this, I thought it is essential to include this, the role of hormonal contraceptives and DVT. Combined hormonal contraceptives, whether they are given as pills, patches, or vaginal rings, always increase the risk of venous thromboembolism. While progestin-only contraceptives, whether they are given as pills or IUDs or subcutaneous implants, do not increase the risk of venous thromboembolism. So over the last 12 to 13 minutes, I have been dwelling on the deep vein thrombosis and pulmonary embolism, the salient aspects, as well as the aspects related to a case of pregnancy. Well, let us say thanks to this man who brought out the three factors involved in DVT: endothelial injury, altered blood flow, and hypercoagulability, the famous Virchow's triad. And thank you all for the patient listening. Thank you.
Thank you so much, Professor Karnadas. That was very enlightening, and you made it short, succinct, and to the point for our audience over here. I really appreciate that. Our next speaker for this afternoon is Dr. Ajit Menon. Needs no introduction again. He's a senior consultant cardiologist at Lilavati Hospital. He's going to be talking to us this afternoon about acute and chronic coronary syndrome. Dr. Menon, the stage is yours.
Good morning, friends, and good morning to the members of the PCOS Society, and a big thank you to the organizing committee and the CSI for having me over to give this talk on management of chronic coronary disease and acute coronary syndrome, which is a large topic to be covered in 15 minutes. Well, we do know that coronary artery disease is a pathological process which is characterized by plaque accumulation in the epicardial arteries, whether they are obstructive or non-obstructive. Usually, they can have long stable periods, but they also become unstable at some point of time, and basically that's because of plaque ruptures, and that defines the transition from chronic coronary artery disease to the acute coronary syndromes. Most frequently encountered scenarios, usually patients with chronic stable CAD and chronic stable angina symptoms. Some patients will present with acute onset heart failure. Some patients may be asymptomatic or symptomatic with stabilized symptoms less than a year after an ACS or more than a year after an acute coronary syndrome or revascularization. And some patients may have suspected vasospastic disease. And of course, you have a large amount of patients who are asymptomatic, which are detected purely on screening, and they do not come to light otherwise. Most important part of angina, of detecting chronic or unstable angina, is the history taking. And usually you look for symptoms like fatigue, faintness, nausea, burning chest, and then the chest, restlessness, or very often they say that, a sense of ghabrahat or a sense of impending doom. And these are usually exacerbated by exercise, exacerbated after meals. There's something called as walk-through angina, and the threshold may vary from patient to patient. If you talk about typical angina, you have a constricting discomfort in the middle of the chest, which is precipitated by exertion, relieved by rest, and this may radiate to the neck, jaw, shoulder, or arm, anywhere above the umbilicus and up to the angle of the jaw. We call it atypical angina if it meets two of the characteristics. If you call it chronic non-angina chest pain, if it meets only one of these characteristics. And the differentiation of stable versus unstable angina is that unstable angina presents as rest angina, new onset angina, and crescendo angina. There's a low, if you define a low risk in unstable angina, if there's no recurrence, no heart failure, no EC changes, and no increase in the troponin levels. And here you see that as the symptoms worsen over a period of months or years, the risk increases. And if you treat them in between, the risk definitely goes down with adequate therapy for secondary prevention. The basic investigations, as all of us know, is the ECG, a 2D echo, and ECG monitoring, ambulatory ECG monitoring, X-ray chest, and in some patients a stress test. And of course, there are biochemical tests. And today, there's a huge hype on CT calcium scorings. The reason why we use these non-invasive tests is to detect myocardial ischemia through ECG changes, wall motion abnormalities, and perfusion changes through SPECT or PET CMRs. Of course, the nature of investigations goes through usually non-investigation and non-invasive testing. And if it is positive, you either give a drug therapy or you can today go in for a CT coronary angiogram. And in case of ongoing symptoms, do an invasive angiography in these patients. There are certain risk calculators which help us in guiding the treatment of chronic disease. One of them is, of course, the Framingham risk calculator, which is one of the earliest risk calculators based on these 4 parameters. And you have the SCORE risk calculator, which is based on gender, age, cholesterol, systolic blood pressure, and smoking status. And recently, they have the SCORE 2 and the SCORE for older patients. The determination of the likelihood depends upon the presence or absence of an abnormal ECG, presence or absence of coronary calcium on CT. So absence of calcium does not mean no coronary disease. Of course, a high probability if there are ECG changes, abnormal ECGs, LV dysfunctions. When you come to treatment of chronic stable disease, of course, the most important part is lifestyle modification in terms of smoking cessation, healthy diet, physical activity, healthy weight, and medications to control risk factors. And this is a very common thing, a common factor with smoking cessation, which is not so easy, but we need an active, aggressive, passive approach in asking them to quit smoking. Pharmacological management of chronic stable disease includes anti-ischemic drugs like nitrates, beta blockers, calcium channel blockers, and of course, the use of statins, antiplatelets, and they're not anticoagulants, antiplatelets, aspirin, clopidogrel, ticagrelor, and prasugrel, use of nicorandil, and of course, the use of evaporatin, which is a beta blocker with selective effects on the heart rate. When we come to the management of ACS, or acute coronary syndrome, the important part is when do you go invasive in these patients? And the focus is on oral antiplatelets. Why do we, again here, we need to stratify the risk. Why do we need to stratify the risk? And that's basically because the mortality of any of these the disease spectrums depends upon the risk and the poor, and you know that there's a poor survival rate in high-risk patients. And there you need to be aggressive in giving the right treatment. The diagnostic algorithm begins in the ER, where you need to try these patients depending upon the ECG and the troponin values and decide whether they are non-cardiac or they fall into what we call as non-ST elevation MI or ST elevation myocardial infarction, which is the actual infarct status that happens. And the triage can help in ruling out or in ruling in the presence or absence of non-ST elevation MI by looking at the troponin values. And of course, you look at CT angiograms or other invasive imagings in case there is a reason to doubt that these patients may be a high suspect for an NSTEMI or for evolving ST elevation myocardial infarctions. There are differential diagnoses of acute coronary syndromes in the acute setting of chest pain. You need to rule out all of these, whether it is cardiac, pulmonary, vascular, gastrointestinal, orthopedic, others. And that's where the triage of these patients comes into effect. And you can easily rule in or rule out in most of these cases the presence or absence of coronary syndromes. In case of non-ST elevation MI, there are two risk scores. One is a TIMI risk score based upon certain 4 historical parameters and 3 parameters on presentation. And this is a score of 0 to 7. And depending upon the risk score, we know that the mortality increases as the risk score increases. We classify them into mild, moderate, and severe. And it has shown in terms of validation that there's an increasing event rate with increasing TIMI score. And it's a very simple bedside tool. The GRACE risk score is the other part of the scoring, which is again based upon certain parameters like age, heart rate, systolic blood pressure, CLIP class of the patient, and the value of creatinine. And also certain dynamic patterns, which help us in calculating what is the risk score. And we calculate them as low, intermediate, or high, depending upon the risk score. And of course, on the right-hand side, you can see that the in-hospital deaths are directly correlated to the risk scores. So this is again a multinational perspective, and it's a very simple scoring system which can be done on the bedside, helps us in deciding how to treat these patients. In terms of the management algorithms, when we look at the definite or likely NSTEMI MI, we need to have an early invasive strategy and initiate aspirin and P2Y2 inhibitors like clopidogrel, ticagrelor, or anticoagulants, and then triage them into either an angiography with angioplasty or a bypass surgery. If it's a bypass surgery, you need to discontinue ticagrelor and clopidogrel at least 5 days prior and prasugrel 7 days prior to an elective CABG. In terms of factors associated with appropriate selection of patients, we have the groups of early invasive and delayed invasive, where the risk score is more than 140. There's a change in the troponin values and new or presumably new ST depression. And in delayed invasive, which is more than 24 hours and between 72 hours, in patients with renal insufficiency, reduced LV systolic function, post-infarction angina, and if you have had a recent angioplasty within 6 months or a prior bypass surgery. In terms of recommendations for coronary revascularization, hemodynamic instability or circulatory supports, refractory angina, life-threatening arrhythmias, mechanical complications of MI, heart failure, and presence of ST depression more than 1 millimeter to more than 6 in more than 6 leads, which is a class 1 indication. It's also recommended in those patients where a diagnosis of NSTEM is suggested and the GRACE risk score is more than 140. In those patients whom we're not sure about the strategies, you can do a CT coronary angiography to detect the presence or absence of coronary disease. The use of PT vital inhibitors, which is a major issue as far as treating patients with coronary disease is concerned, and it becomes a problem when you have to take these patients for any non-cardiac surgery. You need to understand two things. One is that aspirin is a thromboxane A2 inhibitor. The P2 vital inhibitors are ticagrelor, clopidogrel, and prasugrel, of which clopidogrel and prasugrel bind the platelets irreversibly. Ticagrelor is a reversible calculation. In terms of clopidogrel, it has proven its worth in the treatment of unstable angina and has improved the mortality in all the studies that have been conducted so far. And as far as clopidogrel is concerned, as far as the use of limitation, as for the limitations of clopidogrel is concerned, there is an individual variability in response and a low level of platelet aggregation in some patients. And in some patients, you have what is called as clopidogrel resistance. And that's seen in about 5 to 44 patients of 44% of the patients worldwide. And that is why one of the major factors in the treatment in the use of clopidogrel. Prasugrel is again an irreversible binding. There have been various studies of prasugrel in invasive management, non-invasive management, but the issue has been that there has been an increase in the cardiovascular death and TIMI major bleedings in patients who have been in patients who have used prasugrel as an initial management in the setting of a non-ST elevation myocardial infarction. So it is recommended that prasugrel pre-treatment non-ST elevation MI is not actually recommended unless the angiogram has been done and there is a role of revascularization because of a 3-fold increase in the incidence of TIMI major and non-CVG bleeding, and is almost 6-fold increase in life-threatening bleeding with prasugrel pre-treatment compared with no pre-treatment. What about ticagrelor? Ticagrelor has been studied widely. And one of the major studies was a plateau NST elevation ACS study, which is basically comparing ticagrelor with clopidogrel in over 18,000 patients, randomized to angioplasty or to bypass surgery. And of course, in these patients, it is very well seen that ticagrelor has approximately 17% risk reduction as compared to clopidogrel in reducing the all-cause mortality and myocardial infarctions. No major, in terms of efficacy, it is definitely efficacious and a trend towards better efficacy in cardiovascular death and all-cause death. No major complications or no major difference in the bleeding complications, either whether it is compared to major bleeding or non-CVG major bleeding in the use of ticagrelor compared to prasugrel. Antithrombotic therapy is an extremely important part of the management of ACS. And of course, it depends upon the patient's characteristics, clinical presentation, comorbidities, co-medications, and procedural aspects whether the patient needs to go in for a specific procedure or not. The use of ticagrelor and clopidogrel is well established. Prasugrel still remains a point of question of query. The last point of my talk is the management of ST elevation myocardial infarctions. Of course, we do know that primary angioplasty is the mainstay of treatment. But in our country, fibrinolytic therapy also has a role to play because of various aspects. So the question has always been that can we improve on primary PCI with concomitant fibrinolytics? Should all fibrinolytic patients go to angioplasty? And should only fibrinolytic failures go to PCI? Because of various statistical and logistical delays in the management of STEMI and the non-availability of cath labs, we do have a place for pharmacoinvasive approach where we administer early fibrinolysis using a fibrinolytic agent and then systematically perform an angiography within 3 to 24 hours after the start of fibrinolytic therapy. And in case there's a fibrinolytic failure, that window is reduced and the patient can be taken up earlier. The reason for so much stress on this approach is that time is myocardium. And for each 30-minute delay in the treatment of a patient, the 1-year mortality increases by 7.5%. The mortality benefit primary PCI is lost if PCI-related delay exceeds 60 minutes. And practically, early fibrinolytic therapy can compensate for any angioplasty-related delay. where is it indicated? It is appropriate for patients with ST elevation MI who are eligible for treatment with fibrinolytic agents if the transfer time is more than 30 minutes from a peripheral hospital to a PCI capable hospital, or the door to balloon time is more than 90 minutes. And or if in the hospital, the angioplasty related delay, there is a door to balloon minus door to natal time is more than 60 minutes. Our basic aim being to shorten the time to reperfusion of the infarct related artery. There are certain pros and cons of using a lytic before angioplasty. The most complicated being bleeding diathesis, prothrombotic state, cost, and a slightly higher incidence of stroke in these patients. The guidelines clearly state the primary angioplasty is the gold standard of treatment, but where this is not possible, fibrinolysis should be performed with a fibrin-specific agent as soon as possible within 10 minutes from the STEMI diagnosis. However, in our country, the use of streptokinase as a primary thrombolytic agent is still a major role in a lot of rural areas due to inaccessibility to the fibrin-specific drugs. And in the first 3 hours of an event, primary angioplasty and fibrinolysis are head-to-head, with fibrinolysis equivalent to that of a primary angioplasty if the delay is more than 120 minutes. And as time passes, primary PCI is probably a better option than thrombolysis because of various factors associated with fibrin binding within the platelet-rich thrombus. And these are certain flow charts as far as the management is concerned. The basic aim of treatment being to achieve fibrinolysis or an open infarct artery within 120 minutes of the first patient contact. Again, the same that if you have delay in the PCI, we'd rather thrombolyze these patients and then transfer the patient to a PCI-related center so that there's optimal management of these patients. Recommendations are that reperfusion should be given to all patients, and there are 2 registries in India, the CREATE registry and the Kerala STEMI registry, which shows that a lot of patients in India do not get appropriate treatment for ST elevation MI or non-ST elevation MI. And a lot of these patients go home without the appropriate drugs also. So that needs to be a sea change as far as the management of ST elevation MI is concerned. So I hope I have conveyed to you a brief about the management of chronic coronary syndromes and the management of acute coronary syndromes in whatever time frame I had. The basic remains that we need to save muscle. We need to save the heart, the muscle in order to achieve a better long-term result, because heart is one muscle which once it is damaged, it never recovers, and you have to live with it a lifetime. Thank you very much for your kind hearing.
Thank you, Dr. Menon, for your well-delivered and covered talk on management of coronary syndrome, both acute and chronic, in PCOS women. So the final talk of the session is on management of acute ischemic stroke in PCOS and will be delivered by Dr. Raghunath Balakrishnan. Dr. Balakrishnan is a senior consultant, neurology, Sun Medical and Research Center, Thrissur, Kerala. Dr. Balakrishnan.
Good morning. The topic allotted to me is acute stroke treatment. And I must thank the organizers for having given me this opportunity. It's an honor and privilege. A special thanks to Dr. P.P. Mohan. You should all, before the start of the talk, I'd like to remind you that stroke is very heterogeneous. And you have all these different kinds of pathophysiological mechanisms. You have penetrating artery disease, that's small vessel disease. You have intracranial, that's medium-sized. Then you have large vessels like carotids, which can be affected with plaque and arteriogenic emboli. Then you can have flow-reducing carotid stenosis, and you can have aortic arch plaques, atrial fibrillation, the cardiogenic emboli, left ventricular thrombi. So, and from valvular heart disease. So there are the pathophysiology is heterogeneous, and the cause of stroke is very important before we consider the treatment. Now, the stroke evolution has been in the recent years mainly with thrombolysis. So the main advances have been with intravenous thrombolysis as well as mechanical thrombectomy. And this shows the stroke evolution of treatment, and the trials which are put above that is on the top of the slide is actually intravenous thrombolysis. And the initial ones were all intravenous thrombolysis, and later on you have a few very recent ones which again is trying to extend the time window of thrombolysis. And down below, you have mainly the mechanical thrombectomy or the endovascular trials. There is a cluster of them. And the ones which are marked in blue are the antiplatelet drugs, the trials of antiplatelet drugs, chance, point, as well as Thales. I'll just make a brief mention of the antiplatelet drugs, but mainly spend on the intravenous thrombolysis as well as endovascular treatment. Intravenous thrombolysis has been there for the last 26 years. It started off in 1996 when the NINDS trial was successful and the FDA approved intravenous alteplase as a treatment for acute stroke. After that, there has been some extension of the stroke, the time window by various trials which are following that. And then you had this extension from 3 to 4.5 hours. So that now IVTPA is considered to be the standard therapy to give it the first 4.5 hours of stroke. And this is the pivotal trial which by which the IV alteplase was actually approved by the FDA, and you can see the great improvement in the NIH stroke scale, Barthel index, modified Rankin scale, as well as the Glasgow outcome scale. So it was found to be beneficial in all outcome points. So this is a functional analysis, a pooled analysis of 9 trials, and you find that there is a waning of benefit after a certain point of time, and this point of time is now considered to be about between 4.5 hours and 5 hours. So that 4.5 hours is now taken as the time after which the administration of the IVTPA is not beneficial, no longer beneficial. And there is very good evidence indicating that this is a trial, again, a pooled analysis of 9 trials. I think it's shown that beyond the time of 4.5 hours, you find that alteplase is actually worse, and before that, alteplase is better. And it's given as an infusion. Alteplase is usually given as an infusion over 60 minutes. The 10% of the dose is given as a bolus over 1 minute. It's very important to measure the BP and see that the BP is in the range, that is 180 by 105. And then you have to take the necessary precautions. And the treatment of hypertension before thrombolysis is also very important. And the drugs which are used are usually labetalol is the drug which is commonly used. The other drugs which are approved are nicardipine and clevidipine. The usual drugs and hydralazine and naliprate are also used. The usual drugs, NTG as well as sodium nitroprusside, are frowned upon because it might increase the ICP and because of the steal phenomenon. So if you consider the benefits versus harm, in the initial hours, IVTPS found to have enormous benefit. The NNT is 8, and you can see the benefit versus harm. Harm is this one, and this is the benefit. In the first 90 minutes, the benefits over harm is enormous, and it stays on for the next 90 minutes. That's the first 3 hours, you get a good benefit, and the number needed to treat is 8. While after that, till 4.5 hours, you still have an NNT of 14, and you find that the benefit actually outweighs the harm. But beyond that, you find that the harm outweighs the benefit, so that you don't give TPA after 4.5 hours. So the AHA-ASA guideline, the latest one is in 2018, and there has been some updates. And again, it shows that there is a new indication also for IVTPA, in the sense that IVTPA is now considered in patients with minor stroke in certain circumstances. Otherwise, the PRISM trial had actually actually shown that mild stroke, in very mild stroke, IVTPA is not as beneficial as in the other cases. But in certain cases where even a minor stroke is considered as disabling effect, like in a complete heminopia, severe aphasia, which is again just 2 on the NIH stroke scale, visual or sensory extinction, any weakness limiting sustained effort against gravity, and especially if the dominant hand in a person, for example, a manual laborer or a skilled mechanic or a skilled carpenter, it's very important to consider that when you think of giving IVTPA or not giving IVTPA. So even very minor deficits in which the NIH score is less than 5, you can still give IVTPA provided these minor deficits are supposed to be non-disabling. And you find that in many cases, if you look at the frequency of patients coming with stroke, you find the frequency is very high, below 6. So the TIAs and below 6, the minor strokes are much higher than the other ones. So that is why most of these people are actually denied IVTPA. So in these cases, you can, this fits this criteria, you can actually give IVTPA. And it's also important to note that urgent anticoagulation with the goal of preventing early recurrent stroke, halting neurological worsening or improving outcomes after AIS is not recommended for the treatment of patients with AIS. That is again from the AIC guideline. Now there's another question is what agent to use for IV thrombolysis. Another agent which has been tried is tenecteplase. Tenecteplase is not approved in certain countries. In India, it is approved. So we have started using tenecteplase in place of alteplase because it's easier to administer. It's more fibril specific and it can be given with a IV push. So you don't take that much time to actually administer the dose of tenecteplase. And if you want to drip and shift, that is, if you want to give a patient comes to you with a large vessel occlusion and you feel that's a patient for mechanical thrombectomy or IV endovascular therapy, then you can always give tenecteplase and then shift the patient to a center where endovascular therapy can be done. So that's the advantage of tenecteplase. But alteplase takes about 1 hour to administer. So you'll have to, the drip has to be on flow while the patient is being transmitted. Now, these are the trials. Again, most of these are phase 2 trials with small number of patients. All of them have shown a result which is favoring tenecteplase, at least a little bit. Anyway, it is not inferior to alteplase. So the other, there are various other new trials, that's phase 3 trials, the Extend IA as well as Nortest have used tenecteplase in much larger patients. And in these patients also, they have found that, especially in Extend IA, where angiogram was done after administration of tenecteplase, they found that there is higher recatalyzation rate with tenecteplase compared to alteplase. So maybe tenecteplase is the drug of the future. So in future, maybe we'll be using more of tenecteplase rather than alteplase. The next group is the endovascular thrombectomy or the endovascular therapy. Thrombectomy, this is, again, this was actually approved by the FDA after a cluster of trials, about 5 trials, which came out in 2015. So that is a time which was landmarked in the treatment of stroke. And this is the Hermes collaboration, where they actually did a meta-analysis of all these 5 pivotal trials and found that in patients with acute ischemic stroke caused by occlusion of proximal anterior circulation, there is benefit. Endovascular thrombectomy is of benefit. That is what they found out. And these are the results which shows that the benefit is there. And they show that the harm is also very little compared to the control population. That harm is, of course, the symptomatic intracranial hemorrhage, which is what people are scared of when you treat acute stroke. Now, again, Hermes is a pooled data analysis of 5 endovascular trials, 634 intervention cases versus 653 controls, median time to treatment 3 hours and 16 minutes, 71% recatalyzation achieved, and NNT to reduce 1 point in modified Rankin scale was 2.6, which is very high. And very many authors actually believe that it's not 2.6, it's about 3, 4, or 5. Even then, it's very good. And you can see the modified Rankin scale, which shows pretty good improvement in the intervention population. And this is another forest plot, which again shows that across characteristics, you find that it's all favoring intervention. Another problem was whether thrombectomy should be done after alteplase or without alteplase. So this is a trial which looked at that. This is a Chinese study, and it again showed that endovascular thrombectomy alone was not inferior to intravenous alteplase plus endovascular thrombectomy. Some endovascular interventionalists actually prefer alteplase, that alteplase need not be given. I mean, that's how they prefer it. But some people won't mind if alteplase is given. And many neurologists want to give alteplase because in case the endovascular thrombectomy doesn't work, or you could not achieve revascularization or opening of the arteries don't occur, at least the patient has the benefit of the intravenous alteplase. And for detecting who is actually in the time window, there has been a few advances, and there are two major techniques by which you can see whether the patient is actually in time window. If you don't know the last known well, and the most common situation where you don't know the last known well is when the patient goes to sleep perfectly fine, and on waking up, he or she has a stroke. And so you don't know when the stroke occurred. So the last known well is taken as about, maybe the patient has slept 6 or 7 hours. It's taken 7 hours before, and usually they automatically fall out of the time window. But whereas in actuality or reality, the patient would have had stroke just before waking up. So one way to know this is by detecting the flare versus diffusion mismatch. So the panel on this side, on the left side, is the diffusion, and this is the flare. So if you find a lesion in the diffusion, but the same area there is no lesion at all, then it's called a flare diffusion mismatch, and this is one. And usually the flare lesion takes about 4.5 hours to appear. So actually, as you can see in the subsequent images, you can find that in this one, there is a faint image here which shows that flare lesion is about to appear. And in this one, the flare lesion is much more marked. So this is later than this one. So when the flare is almost equal to diffusion, it means that it's beyond 4.5 hours. And so there's no benefit in treating with IV TPA. So IV thrombolysis can be given in these patients where you have this flare versus diffusion mismatch. And so MR Witness as well as Wake Up are two trials which actually looked at this, and they found that if you find this mismatch and you find that it's within 4.5 hours of detecting the stroke, then these patients did well with IV thrombolysis. So these are the trials which were done with, again, this is a Wake Up, this is again Wake Up, and this is MR Witness. So again, they showed this diffusion versus flare mismatch. This is again taken from this trial. And you can see that most of these patients did well when you had a good mismatch between diffusion as well as flare. Another technique of knowing who's in the time window is by looking at the CT perfusion or MR perfusion. So if you have diffusion perfusion mismatch, then you realize that these patients will do well with IV thrombolysis or thrombectomy. Now, these were interventional trials. This is DAWN, which looked at thrombectomy 6 to 24 hours after stroke with a mismatch between deficit and infarct. And they found that these patients actually did well even when treated between 6 to 24 hours. So previously, we know that the thrombectomy, the time is usually 6 hours. And this DAWN trial was done to extend the time window. So 6 to 24 hours was what they done. So this actually changed the guideline because the stroke guidelines actually changed after this trial, so that patients within 24 hours, you can actually do this sophisticated imaging and see if these patients are in the window for thrombectomy. So DAWN criteria had a very small core and they showed a very good benefit. While this is another trial which again used similar criteria, again perfusion, diffusion mismatch, and then they had a larger ischemic core. They still showed benefit, even though the benefit was not as much as that in DAWN study. This extend trial was again using a perfusion diffusion mismatch. They extended the time window for intravenous thrombolysis from 4.5 to 9 hours, and they found benefit. Though this did not come into the guideline, this is again a trial which shows that we might be able to extend the time window in future. So this is again the aggregation of all these trials, and you find similar to the IV thrombolysis, where the time of benefit is 4.5 hours. In this one, the time of benefit is about 7 hours. So the blood pressure in acute stroke, there were various trials which looked at it, and probably it's safe to keep the blood pressure between 140 to 180 systolic. And it's very important to keep the blood pressure within certain limits, and it's important to remember that the blood pressure should be different in different stages. Like when you take the patient to the cath lab, it should be between 140 and 180, and after perfusion, it should be kept at 140 to 160. And if it's only partially recanalized, it's 180 to 105. So it's for different stages. This is an important trial, again, the TAILS trial, which again showed that ticagrelor is useful in ischemic stroke or TIA. And but with the caveat that severe bleeding was more frequent with ticagrelor. So in patients who don't respond to or are resistant to clopidogrel, it might be ticagrelor must be useful. And I'd like to stress that stroke units are very useful in reducing mortality. The effect size is actually comparable to TPA, and it's always important to have standardized stroke orders and treatment pathways, adherence to best practices, telemetry, BP vital sign check, neuro check, bedside swallowing, glucose checks, DVT prophylaxis, and temperature regulation. All these make stroke units very useful. Surgery for stroke is done in a few situations. One important one is in a malignant MCA infarction, where you can do a hemicraniectomy, which has been found by 2 or 3 trials to be very useful. Emergency carotid endarterectomy is done in severe carotid stenosis with a partial stroke. And then this is another case where a posterior fossa, there is cerebellar infarction, space-occupying cerebellar infarction, can do a suboccipital craniectomy plus or EVD plus or minus a suboccipital craniectomy. So in short, in the first 4.5 hours, you have to say IV TPA should be given to every eligible patient. Plus, you should also consider mechanical thrombectomy. 4.5 to 24 hours, you should consider mechanical thrombectomy with the aid of a lot of sophisticated imaging. And these are several scales which are used for pre-stroke management. It's very important to know that. So the time is saved in the emergency department. So for acute evaluation, you have to know the time last known well, history of present illness, exam, NIH stroke scale, inclusion-exclusion criteria, and documentation. And this is a triage. So you have to, I think I've covered most of this in the talk. You have to see whether it's a large vessel occlusion, and these patients have to go for endovascular therapy or endovascular thrombectomy. And in patients who don't fit in the criteria, you have access to MRI. You can actually look for a diffusion flare mismatch or a perfusion mismatch and consider mechanical thrombectomy even beyond the time window. To conclude, you have to think of combined thrombolysis with endovascular therapy. Procedural excellence is the best chance for a good outcome. Time is brain. A protocol-based approach saves time and gives best outcome. Stroke unit care matters, and stroke is like cricket. All members of the team contribute, so it's every member is important to have a very good outcome. Thank you.
Thank you so much, Dr. Raghunath, for that extremely enlightening lecture. I had one question about this, Dr. Raghunath. We spoke about, BP targets in patients, like you spoke about, pre and post perfusion. What about their long-term targets for blood pressure? If they're coming to us, maybe 2 years, 4 years later, what should be our targets? Because we are checking, BP in the clinic, and also with regards to antiplatelets, duration, how do you decide when to cut down, how to titrate in the long term?
Yeah, I think my topic was acute ischemic stroke, so I kept to that. But generally, we follow the guidance as by the cardiologist. I mean, we keep the BP according to the guidelines which are provided by the BP guidelines. So that is what we do to prevent the risk of further stroke also. So 120/80, and that is the target BP, and we try to keep the BP as low as possible. So that is the as regards BP for chronic control. Then antiplatelets, we use dual antiplatelet therapy for the first 3 months. That's according to the CHANCE trial. So we use a combination of clopidogrel with aspirin for 3 months after stroke. Then after that, we go on to a single antiplatelet agent if there are no other problems. So that's what we usually do.
And that will be long-term therapy.
Long-term therapy.
Okay, all right. Dr. Menon, I had one question for you, and then I will hand over the mic, Dr. Haldar. So, today we have asymptomatic females coming into the gynecology clinics, they peri or post-menopausal, and they are PCOS women, say. We know that they have an insulin-resistant background. They are often obese. in this kind of woman who's coming for a routine follow-up, do you suggest screening with any questionnaires / any testing further than that, just due to their history of PCOS? Asymptomatic otherwise. Your mic, please, Dr. Menon.
I mean, we do know that PCOS possibly has a higher propensity for developing coronary disease because of the hormonal issues that are there. And historically, it has a higher incidence of CAD. I think beyond the age of 40, anyone coming with PCOS should be investigated in terms of at least a basal ECG, a baseline blood reports, because what we can control are the controllable risk factors. What we can't control are the non-modifiable risk factors, which include age, sex, family history, history of associated conditions like PCOS. These are non-manageable. These are non-controllable. You can control is your blood sugars, your hypertension, your cholesterol. So get those basic investigations done. Unless they are symptomatic, I wouldn't go for anything beyond that in terms of a stress test or anything. Of course, if these people additionally have a family history, have familial hypercholesterolemia, familial hyperlipidemia, then yes, you may add a stress test or one of these investigations onto it.
All right. And do you recommend any of the screening questionnaires that we've heard about? I mean, are we practically doing that? Should we be doing that in our clinic?
I think it's worth doing it because we're seeing a higher incidence of youngsters coming with coronary disease today, and I think one thing I can tell you is that we don't know what are the scars that COVID is going to leave behind.
Right.
And that is one situation which is scary in terms of thrombotic states and hypercoagulable states coming in much later and much after the initial COVID insult. So we are still in a very gray zone as far as that is concerned. And I think we need to we need to keep our ears and eyes open. I think we need to probably be a little more aggressive in the coming years in terms of investigating patients. It would definitely be a better bet. It doesn't, you don't lose anything. You probably will catch a few patients much earlier than what you would otherwise present with.
Right. Thank you for that. And Dr. Karunadas, since we've just spoken about COVID and the vaccines and the whole thrombotic potential, any words of wisdom for us on that front as well?
Karunadas is attending another session, so don't you worry. But then it's okay. But the general advocacy is for the inpatients admitted with symptoms and a rise in biomarkers like a D-dimer or others, that will possibly, there is no definite consensus yet, but many of the people believe that if the D-dimer values are more than 3,000 units, then these are the patients who merits anticoagulation. But all admitted patients, then necessarily has to be anticoagulated.
Okay, thank you very much. Dr. Haldar.
Thank you. First of all, I thank all the speakers for a well-delivered talk. I have, this is not a really question, just some information to get from all your experience, and question directed to all three super specialists. So my inquiry is how frequently you come across with any of all three presentations like venous thrombosis, pulmonary embolism, or acute coronary syndrome, or even stroke in non-PCOS case. I mostly less than 45 years age. Do you have any data on that? Patient presented female less than 45 years with non-diagnosis of PCOS with any of these complications?
PCOS, basically, Ajit, you go ahead.
No, you can go ahead. Dr. Mohan, you can go ahead.
PCOS as such is a complexity of insulin resistance, obesity, deranged glucose metabolism. So basically, we transport the data from these precursors and then gravitate and say that, well, this is the occurrence that's happening in these subsets of people. Unfortunately, as you have seen, now we don't have that solid information in the PCOS separate group. But we say, for example, an obese person who undergoes any surgery, especially orthopedic surgery, the chances of venous thromboembolism is something like 8 to 15 to 20%. So these are the values which are available. Unfortunately, we don't. PCOS is an entity which is gaining attention to everyone. It caught attention of the vascular guys only recently. So we don't have any precise data on that.
I agree with Dr. Mohanan on this. The thing is, when if you're looking at non-PCOS patients, if you look at I don't think there's any study or any data available with us or separately on non-PCOS patients or otherwise. Historically, they say that hormones are supposed to protect the women below the age of the menopausal age. But trust me, today, as far as coronary syndromes are concerned, and I can tell you with respect to strokes, with respect to a lot of other illnesses, we see it much younger. Probably, I would blame the lifestyle for it, lack of exercise for it, dietary habits for it, and one major factor, which is a non-quantifiable risk factor, which I believe really exists, is stress. It's something which is non-quantifiable. You cannot, I don't think there are any studies which you can do to say that this much amount of stress creates this, but I'm sure stress is an integral part of our lives. And I mean, this stress is only gets worse as age advances. And today, much more youngsters are falling prey to stress because of their lifestyles. They want to achieve everything they can by the time they are 40. And that pushes immense pressure on these guys. And trust me, it's not the stress which kills, it's the reaction to stress which kills. So a person who can react very well to stress probably has a longer life. A person who reacts very badly to stress is probably more prone to these events. And I think this goes into the entire cardiovascular continuum, whether it is coronaries, brain, wherever it is.
Ajit, just for information, I have information from our Google doctor saying that the PCOS and DVT, thromboembolism in women, PCOS is 23.7 per 10,000 patient years, while non-PCOS, it will be 10.9 per 10,000 patients. So there is a difference.
And I think, Dr. Menon, as you so rightly said, with PCOS girls, they are facing different types of stress from an even younger age, more so than our routine teenagers. And so, yeah, that's totally.
That's because
I do agree, Dr. Menon, that stress probably the most important determinant of all this kind of problems, because stress, see, most of the PCOS, they have infertility after marriage. And that infertility itself is a very stressful situation for the woman, and that leads to all kind of, I think, metabolic syndromes initiation, and it's a business cycle and keeps on going on.
If you see the spectrum of patients that we see and the problems they come to us, it's vastly different from the older generation. So I'm sure Dr. Raghu also agrees with this, that even among stroke, the age of stroke patients is also reducing. Younger patients are coming with strokes, and I mean it's a very scary scenario today. You know, where our kids are heading towards.
Yeah, I thank both the moderators, Dr. Pia and Dr. Haldar, for moderating the session, and all the three speakers of the session, Dr. Karunadas, Dr. Ajit Menon, and Dr. Raghunath, for their excellent presentations and interaction. We now move on to the last session, and that is a panel discussion on preventing cardiovascular events in PCOS women. And the topics which would be discussed under this would be lifestyle changes, management prior to surgical procedures, and what needs to be done during COVID times, and what should alert the gynecologist, and what the gynecologist should do. We have none other than the CSI President, Dr. Mohanan, to moderate the session. Can I have a CV, please? Yeah, he's the President of Cardiology Society of India, and he's the Director and HOD of Cardiology at the Westfort High Tech Hospital in Thrissur, Kerala. Second moderator for today's session is none other than Dr. Pankaj Desai, who is a gynecologist from Baroda, and he has been the past president of Foxy. He was also the former dean and associate professor and head of unit at the Medical College of Baroda. He has several awards to his credit, and his areas of interest are obstetric vasculopathies, immunology of pregnancy, preeclampsia, IUGR, and recurrent pregnancy loss. I would, next slide. Our panelists for today are Dr. Cecily Mary, who is the Chief Civil Surgeon, Department of Cardiology, and a consultant and interventional cardiologist at Apollo Spectra Hospital, Chennai. She has several awards to her credit. Next. Our second panelist for today is Sheba Thakkar, who is a professor in the Department of Cardiology at the DMC Heart Institute, Dayanand Medical College and Hospital. And she also has several awards to her credit. Next. Our third panelist for today is Debrata Roy, and he's a senior consultant cardiologist at the Narayan Hridayalaya at the Rabindranath Tagore International Institute of Cardiac Sciences, Calcutta, Bengal. Next. And we have none other than Dr. K. Venugopal, who you all have already heard. He's a professor and head of the Department of Cardiology at Trivula. He is also the fellow at the Cardiological Society of India and of the Indian Cardiology College of Cardiology, American College of Cardiology, and European Society of Cardiology. His areas of interest are preventive cardiology. Next. And the last panelist for today is Dr. D.P. Sinha, who is a senior consultant cardiologist at the ILS Hospital, Dum Dum, Calcutta. I now request Dr. Mohanan and Dr. Pankaj Desai to take over.
Thank you, Madhuri. Incidentally, Dr. Debrata Roy is the Honorary General Secretary of the Cardiological Society of India, and Dr. D.P. Sinha looks after our coffers. Okay, so we have the entire cardiology team to represent. And thank you for this association. Fortunately for all us, most of the subjects that we are going to discuss has been covered in some way or other. But anyway, it's always good to wrap up and re-emphasize certain things. So let me ask Dr. Professor Sinha initially. Now, we heard about something about the metabolic disorders, glucose intolerances, and diabetic status in PCOS. You can just come out with the most important pointers in this. Dr. Sinha, please. Dr. Desai, you are free to shoot questions anytime.
Sir, I have been shot.
Okay.
Yes, please.
Good afternoon to everybody, and thanks to the organizers for asking me to be present here, and thanks to P.P. Mohanan President for giving me this question. You know, the PCOS definition I will not repeat, but the central part of it is hyperandrogenism. Thing is this: if you really look into the pathophysiology of PCOS, insulin resistance is the key dialogue in PCOS pathophysiology, and insulin resistance is in various studies. It has been reported from 30% to 30% of the female patients have insulin resistance, and frank type 2 diabetes mellitus is present in approximately 10%, which is more than 10 times the normal average diabetic status in non-PCOS women. Now, why this thing happens in PCOS women? There are various theories, but again, scan of the literature will tell us that insulin resistance is the key cornerstone, which actually there are several metabolic disturbances that have been described, like the decreased phosphate insulin release, decreased insulin deposition, glucose deposition, and increased hepatic neogenesis. And this can be all due to some sort of cell culture studies have shown that there is some sort of defect in the glucose transporter 4 mechanism, which actually transports glucose from tissue fluid inside the cells. And this has led to certain conjectures which has not actually been very much proven right now, but this insulin resistance led to increased insulin in the peripheral blood, and this hyperinsulinemia actually leads to increased thecal cell stimulation, which leads to increased androgen secretion, and also increase in the aldosterone secretion from the suprarenal glands. So, having said that, the insulin resistance and is a key cornerstone, one of the key mechanisms in the development of PCOS in the female population. Now, what do you know about actually this impact of this insulin resistance? Insulin resistance will impact the various metabolic syndromes in various ways. It leads to increase in triglycerides, it leads to increase in the weight, it leads to increase in the blood pressure, everything. All of this can be attributed to the insulin resistance. So in short, insulin resistance is one of the key pathways in PCOS, and maybe tackling it will be the one of the key treatment strategies. But that we'll come to that later on. Thank you, Dr. Manan.
Thank you. Thank you.
Dr. Manan, may I a little?
Please.
Sir, I am a practitioner, though teacher and academician. One question which always bugs me when I'm sitting in my clinic, and today before 3 years, I was sitting on the banks of river Ganges, and I was feeling blessed. Today, I am sitting in front of river Ganges, of flowing knowledge of such wonderful cardiologists whom I wanted to catch hold of many times. And sir, my question through you is that can we identify, we as clinicians, before you people pick up the insulin resistance and all, which Dr. Sinha has wonderfully said, can we pick up risk factors, clinical risk factors, young and a little matured in our clinical practice, and then send you if need be? Please, can any of the wise people help me in this, please?
Sinha, you haven't want to take that up?
Yeah, that is a wonderful question. You want a, let's say, primordial prevention of PCOS. See, if you really want to do that, you have to promote healthy lifestyles, just as our last speaker said, that many of the diseases that we see today is part of the lifestyle disease. It's related to food, it is related to exercise habit, it is related to societal practices. So you have to catch hold of these young girls and teach them about what the healthy lifestyle. But it is difficult, the India is currently going through an obesity epidemic in a certain part of the population. We have got both obesity epidemic and also the hunger epidemic in another part of the population. So that is where the insulin resistance comes in, that if you really do not work hard, you will get resistance.
Dr. Desai, the fundamental things that when we talk about preventive cardiology is your importance on lifestyle modifications. Your diet, your exercise is the one which matters most important, and that will apply to every compendium of PCOS patient. And I was just about to say that there are about, as per our data, 74 million diabetic. Possibly we have not included the PCOS. Now your Rotterdam criteria says about 10 to 22% of women has this thing. So another 20% of these people have diabetes. So it's an unimaginable number that we are going to see.
Dr. Mohan, can I add something?
Please go ahead. Please go ahead.
Yeah. I think Dr. Desai has raised a very interesting point. And I think there has been a paper published way back in 2009, where the different ovulatory phenotypes of PCOS, they are compared for their metabolic profile risk. And I don't know whether you are still with that phenotypes, though there are phenotype A where you have hyperandrogenism along with anovulation plus minus PCOS, where they're called depending on the presence or absence of PCOS, they're designated as PCOA type, phenotype A and B. Next, these are the NIH phenotypes. Then we have two non-NIH phenotypes. One is phenotype C, where you have hyperandrogenemia, but they have ovulation. And another is phenotype D, who are normoandrogenic, but anovulatory. So what they have found, you have, and I think now the terminology has come into three. One is classical phenotype, the second is ovulatory phenotype, and third is normoandrogenic phenotype. So overall, it is seen if you have a classical phenotype, they have the highest risk to develop cardiometabolic disease.
Okay.
When you consider phenotype C or maybe the ovulatory phenotype, if they have central obesity, then you should be cautious that these are the patients who require tight screening. And the last phenotype, that is the normoandrogenic phenotype, but anovulatory. Normoandrogenic, anovulatory, they carries the least risk.
Thank you, Dev.
Thank you, wonderful. Thank you, sir.
For highlighting these phenotypes. Shiba, let us talk about, we have heard about importance of hypertension, whether it is in the genesis of CAD or stroke, but what are your pointers for the hypertension statistics, not by statistics, but the management part, which our gynecology friends may be interested in?
Yeah, indeed, it's a very interesting question, and something which can be seen in our OPD practices very easily is the blood pressure, which indeed our patients do get checked when they come to us. So we know that because of its incipient risk factors, as Dr. Debabrata Roy just now pointed out, we have 4 types of PCOS, and it's type A and type B PCOS actually, which are maximally associated with most of the cardiometabolic risk factors, hypertension being one of these risk factors. So an increased aldosterone levels and activated renin-angiotensin axis, increased insulin levels, we've all discussed about insulin resistance, and impaired autonomic nervous system and depleted nitric oxide levels, they all do contribute to hypertension in our patients. And yes, definitely PCOS by statistics is also related, as sir was just now pointing out. There's a Brazilian study, there's an Australian study. The Brazilian study of around 233 PCOS women, when compared to controls, it found that there was 65% incidence of hypertension in patients with PCOS vis-a-vis just 40% in the control groups. And, there was another Australian study which studied, and it found that this rise in blood pressure was not really associated with a high BMI that these patients are actually having. So hypertension per se was increased in patients with PCOS. And I think as gynecologists, sir was just now asking when we need to be aware and be picking up these patients, is that we have our ACC guidelines, and elevated blood pressure, it comes somewhere in the risk by stringent control of 120 to 129 millimeters of mercury and diastolic of 80 to 89. So we should look at this pre-hypertensive levels and consider them for management. And here's where the gynecologist colleague can think of a cardiologist friend and work in hands for managing these hypertensive patients.
Thank you so much, because please keep the gynecologist in mind, because in the previous sessions when I was there, Dr. Bohanan is our boss. He told me, be here on time. And I was here and the sessions were still going on, and I felt like I am listening to a Telugu or a Malayali song. They are so beautiful, but I can't understand anything. But now I am able to understand, thanks to all of you, Dr. Debrat, Dr. Shiba, Dr. Mohanan, Dr. Sinha, because I am a gynecologist. I am sitting there and I need your help, and I don't want to let you go today without giving me some answers, please. And
don't you worry, Dr. Desai, we are all here. Dr. Majella, we have again mentioned about dyslipidemia pattern, but let us discuss about the type of dyslipidemia that's happening in the PCOS population, please.
Thank you, sir. Thank you for this golden opportunity. Very good afternoon to one and all. Coming to dyslipidemia and PCOS, in a recent meta-analysis, it has been analyzed in detail, and it was described by Wild et al. That in PCOS, the triglycerides are elevated up to 26 milligram per deciliter when compared to the non-PCOS group, 8-MAT controls, as well as the LDL levels are increased up to 16 milligrams per deciliter when compared to the non-PCOS group, and the HDL levels are decreased up to 6 milligrams per deciliter when compared to the non-PCOS group. This is regarding the lipid profile. And when coming to the LDL levels, not only the serum levels of LDL are reduced, there are in PCOS group, there is increase in the density, the small density atherogenic, more atherogenic LDL is increased. The small dense LDL is found to be increased in this meta-analysis in the PCOS group. Then another important observation was that the ApoA1, which is for the HDL, high density lipoproteins, are found to decrease in PCOS. Thus, the anti-atherosclerotic effect of ApoA1 is found to be reduced in PCOS women. And when coming to ApoB, there was not much difference. Whereas in ApoC1, it was further emphasized by Huang et al., who has shown that this ApoC1, which is the earliest marker or which is mainly responsible for inhibiting the triglyceride receptor uptake, the triglyceride uptake by the hepatic receptors, which is inhibited by the ApoC1, was found to be elevated in patients with PCOS, thus leading on to increased postprandial lipid levels. And another important thing, the Korean study which compared the obese PCOS and non-obese PCOS, though there was triglycerides was not much elevated in the non-obese PCOS, this Korean study has concluded that lipoprotein small a is elevated in all PCOS subjects, be it non-obese or obese. So to conclude, the final thing is the LDL is raised, TGL is raised, HDL is reduced, ApoA1 is reduced, ApoC1 is raised, lipoprotein small a is elevated, and small dense lipoproteins are elevated. Thank you, sir.
Thank you, Majalla. So it looks like it's more of a complex dyslipidemia and something akin to diabetes. You touched on obesity, Professor Venugopal. Now, taking on that to you, obesity. Of course, now most of the PCOS are obese, even though we learned that you can have a lean PCOS also. Your thoughts on that? Audio, please, Venu.
Can you hear me now?
Yeah.
Yes. See, thank you, Dr. Mohan, and it's a very interesting question. Actually, to be very honest, till recently, I was aware of only the obese PCOS. I was not aware, as a cardiologist, I was not aware of a lean PCOS. 80% of the PCOS patients are obese, and these are the patients who come to us. The non-obese usually do not come to us because we don't have an identification marker for our metabolic problems with this type of patients. Now, when you come to obesity, we know that obesity itself is a risk marker for so many things: cardiovascular, hypertension, even malignancy. There have been a lot of relations with obesity, independent relation of obesity with all these problems. So how do you reduce obesity in this sort of patients? Probably, yes, the first and foremost that every one of us talks to every patient is lifestyle modification. But I do not know how much effective lifestyle modification may be in majority of patients to reduce that. Even a reduction of a few kilograms probably go a long way in changing the profile of these patients. So apart from lifestyle modification, diet, exercise and all that, I think the most important aspect of weight reduction I would concentrate is on exercise. We have to emphasize that at least 30 minutes of exercise 5 days a week, basically cardiac exercise, would be the ideal way of going in for these patients. Second thing is, there are a lot of drugs that have been advised, especially in PCOS with insulin resistance. Metformin has been one drug which has been, I think it's one drug that most of the gynecologists has been using in PCOS. Then appetite reducing drugs have been used. And lately, there have been a lot of emphasis on bariatric surgery also. In patients who are really obese, where you are not able to reduce the weight, there have been issues on, discussions on bariatric surgery also. But on a practical note, I think as far as the cardiologist is concerned and the gynecologist is concerned, lifestyle modification to me is the most important aspect of.
Professor Venugopal, now it's a fashion to take keto diet. Are you a fan of keto diet?
Honestly, no. Because the problem with keto diet is how long are you going to keep on with keto diet? See, these are all fats. When you want to reduce, we have to go very clearly. You want to reduce weight, the most important thing is to reduce your carbohydrates in the diet. See that beyond that, keto diet, maybe it is good for weight reduction, but the point is you stop keto diet and go back again to your normal diet with a high carbohydrate intake, you are again going to gain weight. So the primary aim of weight reduction would be a low carbohydrate as far as I am concerned, rather than going in for food fats.
Okay, right. Debabrata, now the Met syndrome is again gaining importance day by day, and naturally, PCOS is one vulnerable group for Met syndrome. What are your thoughts on that?
Yeah. Sir, Met syndrome is the Achilles' heel of PCOS. It is not uncommon, depending on which data you are looking at, either is it a trial or is it an observation study. The prevalence ranges between 33 to 47% of the PCOS patient who will develop metabolic syndrome. And this metabolic syndrome is important because in a PCOS patient, if you have metabolic syndrome additionally, this will increase the long-term risk of developing coronary artery disease at least twofold and having overt diabetes mellitus by at least fivefold, and which is not often discussed, the risk of obstructive sleep apnea is increased almost by 30-fold. Why this obstructive sleep apnea is important? Because obstructive sleep apnea can worsen the insulin resistance, and which in turn can result into adverse cardiovascular outcome. What is the perplexity between this Met syndrome PCS adjunct? Though insulin resistance seems to be a common platform, but the PCOS and the Met syndrome, there is hardly any evidence to establish any causal relationship between them. So it is not that if you have PCOS, if you have insulin resistance, you will have the metabolic syndrome. It's not like that. In fact, a recent paper published in Diabetes, I think in August 2021, which has done a Mendelian randomization study, they have shown that if you have single nucleotide polymorphisms, which can predispose to PCOS only, is not related to development of long-term cardiometabolic risk. On the other hand, if you have such polymorphisms for developing diabetes, for developing hypertension, for developing adiposity, they have a definite relationship with future outcome. Therefore, it seems with the present data that in a patient of PCOS with metabolic syndrome, you have to treat them as a separate entity and address the risk factors individually. Now, there are several definitions for the metabolic syndrome. And it has been shown in a registry from Greece that if you use the joint interim statement criteria, which has given due importance to the ethnic variation in measuring the waist circumference, so it helps in detecting higher percentage of metabolic syndrome in PCOS patient. However, if you use the age NHLBI criteria, where the fasting blood sugar cutoff has taken to be at 100 milligram per DL, there seems to be a better predictor of risk for cardiovascular events. Now, the thing is that because this metabolic syndrome is very important, you need to screen these patients quite closely. So for every visit, you have to inquire about his tobacco addiction, the parameters of obesity, that is the body weight, BMI, waist circumference. You have to measure the blood pressure. The lipid profile, you have to measure annually, and oral glucose tolerance test also annually. And if your patient is above 40 years and you think that he belongs to a quite high risk group, having these factors like physical inactivity, tobacco addiction, ethnicity, hypertensive, you had a history of previous gestational diabetes, you might subject these patients to CT coronary angiogram to see whether the score is above 100, and you can initiate statin.
Yeah, we will come to the clinical assessment in a minute. So, Dr. Sinha, so now we have been talking about all the risk and unfortunately, many of these risk factors lead on to CVD. So, what about subclinical CVD? How are we going to pick them up, Professor Sinha?
Yeah, before I go into that, I'd like to make a small point. The PCOS knowledge base, I think it is called PCOS KB2, published manually curated from the different journals. I think they're headquartered in Bombay. And what they have made that there are 545 single nucleotide polymorphism associated with PCOS. So one single SNP is not going to solve all our problems, but that is a different story. Now coming to the question, the subclinical CVD. The thing is this, by this time it is clear, we have been discussing it through ages and at least for 2 days, that it is basically a metabolic syndrome. PCOS is a metabolic syndrome, which is associated with obesity, hypertension, dyslipidemia, insulin resistance or type 2 diabetes mellitus, valid point by Dr. Rai, obstructive sleep apnea, and also mentioned previously, higher aldosterone level. All of these are subject to having an atherosclerotic, increased atherosclerotic cardiovascular risk factors. If you look at what the study, how to study this, you can go for a coronary calcium or a flow-mediated dilatation study to look at the endothelial function, or the intima media thickness, like this studies. But what is the data on this? Databases have looked into this aspect. One is the women's ischemia syndrome. You have number 2 is multi-ethnic study of atherosclerosis, WISE and MESA. Both of them has found that the subclinical atherosclerotic disease in patients with PCOS. Analysis of all the trials show that is double the risk of atherosclerotic clinical cardiovascular disease in patients with PCOS. However, it must be mentioned that in a recently published European Heart Journal data on population based from the I think it was from Denmark, found the PCOS is associated with a higher risk of atherosclerotic cardiovascular disease in between 30 to 50 years. Beyond 50, the association of PCOS with atherosclerotic cardiovascular disease is not very significant. And below 30, there is a very few data to link PCOS to CVD. So having said that, between 30 to 50 is still a very vulnerable population. We have to look for subclinical atherosclerotic cardiovascular disease in this population. Thank you.
Mohan, can I add a point? I think
Sure.
Of the factors which Dr. Sinha mentioned, I think coronary calcium, there has been a data on coronary calcium as a screening for subclinical coronary cardiovascular disease. Even in PCOS, there is some data on this. So I think just like what we do in the other patients, coronary calcium may become one of the markers for subclinical cardiovascular disease in this group of patients whom we are, as Dr. Sinha said, as you grow older, the risk of PCOS regarding cardiovascular involvement also becomes lesser. So
we have listened that from Professor Govindanuni also earlier in our talk. So, Shiba, actually, we had some discussion from Professor Kelkar about the risk assessment various, but then you can possibly convey to our friends here, what will be the best risk assessment methods in PCOS?
Right. So actually, because we were discussing PCOS, I happened to go through a document in 2018, which are the international guidelines for PCOS by NHRM. And when they started the document, they beautifully mentioned for the risk assessment that the clinical risk assessment for PCOS patients should be by the mnemonic SMART. So specific, measurable, achievable, realistic, and timely also. So having said that, they also quoted that there have been several studies for the clinical risk assessment. There were studies and meta-analysis on more than 1 lakh patients, and they found that the stroke was having a hazard ratio of more than 2. Then there was another study of more than 1 lakh patients which found no association with myocardial infarctions. Then came the Denmark registry, and they found that there was an incidence of 22 point some percentages of patients with coronary events vis-a-vis just 11% in patients who were non-PCOS. And then the Australian study, which again found a hazard ratio of more than 2.5 for cardiovascular, cerebrovascular, and even venous events. So having said that, these clinical events are still having, as we said, to some extent they have been reported, yes, but still there is a controversy for the clinical events which are occurring. So when we talk of risk assessment for these events, in a normal patient who is not having a PCOS and we are assessing the cardiovascular risk, the guidelines by ACC recommend that 4 to 6 year assessment is needed by the ASCVD score. So when we talk of a given patient of PCOS, probably the duration has to come down, especially when we are talking of PCOS type A and B, who are having a profile which is hyperandrogenic and who are obese. So in these patients, probably we need an annual checkup. So a patient enters into the OPD of a gynecologist. I believe the gynecologist should have a look at weights. The recommendations by NHRM guidelines are that the weight needs to be checked every 6 to 12 months. We need to look at their BMIs at regular interval, not just the weight. And we also need to have a look at their fasting blood sugar and HbA1c levels. So the usual recommendation is annual, but if we have a higher level of HbA1c and fasting, then every follow-up visit should include the blood sugars which need to be checked. The higher risk factors need to be assessed, and those risk factors are current smoking, any associated oral glucose tolerance, and especially for women who have had history of any gestational diabetes and who have family history of premature diabetes, we need to be more careful and assess these women more regularly. Also, oral glucose tolerance, if impaired, is associated with hypertension. So in women in whom we find more of glucose intolerance, we need to be looking at their ambulatory blood pressure monitoring and look for any nocturnal dippings. It has been reported that nocturnal dippings are less in women with PCOS who have an impaired oral glucose tolerance, especially more so in the Black population.
Superb. This
Dr.
is
Shiba, you want to add something?
Yes. No, I want to ask Dr. Shiba, if you want to finish, you can complete, but I'm going to come
I
to
need
you.
to add one point
Yes,
for
please.
you, Lisa. I found you very concerned, because we also need to look at the male PCOS when we talk of clinical assessment. We cannot, kind of afford not to mention it or not think about it. So male PCOS is an entity which has been reported with underlying polygenic inheritance and has been very well reported in several papers. In fact, there is one of the gene by the name DEN-D1A, which has been mentioned. So male PCOS cannot be ignored. And when I actually read, I was, it was something very good, new for me also, that fathers and brothers of patients who are having PCOS have respectively, I think, around 1.89 and 3.5 times of developing cardiovascular events. So we can't just, finish by clinically assessing the women. We need to look at the family, the fathers and mothers. They should also have a more vigorous assessment once PCOS has been diagnosed in a woman.
I have a question, sir, if you allow me. She is going very well clinical, and for us, for gynecologists, all other speakers have been also very knowledgeable. But here, this is for a gynecologist. It interests me like anything. A small side point on male PCOS. I am, as I told in the practice session, I am a son of a PCOS mother. Who passed away 25, 26 years before. But then, and I had some stigma about it. I mean, a clinical stigma. Ma'am, we are sitting in a OPD, an obese PCOS with a BMI of say around 30, for whatever reasons requires a surgical intervention, a hysterectomy. Then nowadays we go in for laparoscopy. So it's a full general anesthesia. And we send to you for assessment. What do you want us to get investigated before and send to you? And what do you do before you mark as safe for surgery? Can you please tell us? It might sound very, very primitive question, but
very, very interesting, and it is something
bugs us.
Yeah, we deal with it day in and day out. So I think that when we have a PCOS patient who enters to us, we need to look at the patient. So obviously, we would like to do a stress test after assessing the symptoms of the patient. So if the patient is fully active and the activity level of the patient is more than 4 metabolic equivalents, that means that she has enough ability to bear a stress which is surgical. So by 4 metabolic equivalents, we mean that she should be able to do an activity which is slightly more than the routine activity. For example, we can ask her if she is able to climb 2 flights of stairs or not. So if she is able to do that in routine, or maybe go for a walk and get a brisk walk of around 1 or 2 kilometers, that means that this patient is active enough to be able to bear the stress of the surgery. Still, we would like to be extra cautious in a given PCOS type A or B patient who is obese or maybe having an impaired oral glucose tolerance. We can subject this patient to an echocardiogram to have a look at the LV functions, because an underlying asymptomatic LV dysfunction could be common in a patient who is having an impaired glucose tolerance. And yes, do a stress test, maybe like a treadmill stress testing, or if the patient is not able to, we can subject this patient to a stress echo.
As taught by Dr. Venugopal, do you want us to do coronary calcium?
For patients,
you can hear that question Dr. Desai was mentioning.
Venu sensitized us to this. What do you feel?
I think sir is, I can't see sir in this thing.
He's in a I mean, Venu, you can come here. Venu, you can come. He's here with me, don't worry. We are in another meeting, that is the problem. Okay.
No, see, there's one thing is that coronary calcium is actually a screening method for preclinical atherosclerosis.
Okay.
So when you have a high suspicion, for example, then that is a time when you do all these things. Otherwise, not for a routine evaluation.
Thank you. Thank you. Thank you very much.
Okay, now, Majella, now we have again discussion about the importance of hypertension. Do you think your management of hypertension in a regular and a PCOS patient are anyway different?
Sir, the patients that
I will pass it on to Cecily, sorry.
Okay, sorry.
Yes, sir. When coming to the management of hypertension in patients with PCOS, I would like to quote here a study from Chen et al., which was also taken up by the American Heart Association. So the main, as already Dr. Shiva has rightly mentioned, the cause for hypertension in PCOS, apart from the renin-angiotensin system and the hyperandrogenism, as well as the increased testosterone levels, which is the androgen levels are specifically measured by the serum free androgenic index, which contributes both to systolic and diastolic hypertension in PCOS women. So in PCOS in general. Now coming to the management as such, before going on to the drug management, I would like to highlight here the dietary management is also, which is very important, as stressed by the DASH study, that is the dietary approach to stop hypertension. So here also, once again, prior to the thing, AH has mentioned that the salt intake of PCOS women should be restricted to less than 1.5 grams per day. And coming to the diet, a DASH diet, which include lots of fruits and vegetables. There should be at least 5 servings of fruits and vegetables combined together per day, which will definitely found to reduce the BP levels in PCOS women. And the second important thing is increase in the intake of nuts and seeds. And apart from that, omega-3 fatty acids has also shown to decrease a minimum amount of blood pressure, which is also included in the DASH diet. Then finally coming to olive oil. there was a study which was conducted by the American Hypertension Society with the individuals who, PCOS individuals who are taking olive oil containing polyphenols and those patients not taking polyphenols, and it was found that olive oil definitely containing polyphenol, definitely olive oil, those patients taking olive oil, they found that the blood pressure tends to reduce. So first, in those patients who are pre-hypertensive or borderline hypertensive, definitely first modality would be salt restriction and DASH diet. Then coming on to the management per se, as requested, the drug treatment. Here, because it is hyperandrogenism, spironolactone plays a major role. It has been found to even reverse the endothelial dysfunction in PCOS women. And another important thing is AC angiotensin receptor blockers. Of important among that is telmisartan, which is found to increase the insulin sensitivity, mainly by activating the PPAR gamma receptors. So apart from that, the increase in sympathetic activity can be definitely countered by the beta blockers and other drugs as usual. So we give more importance to DASH diet, spironolactone, as well as telmisartan among the antihypertensives in case of PCOS women.
Angiotensin aldosterone system is possibly more important than any other one. So we have covered hypertension. What about diabetes, Dr. Sinha? We know it's a insulin problem here in PCOS. So what are your types of OHA that you will propose to give? Dr. Sinha, are you around?
I think, sir, Dr. Sinha, I think he's attending to a call, I think.
Okay, maybe we will come back to him in a minute. Then, Dr. Venu, are you okay with are you there? You can join. You can join. Come. Now, we were also discussing about the type of lipid lowering therapy. We had mentioned about that earlier. What about the lipid lowering therapy, statins and otherwise?
See, the keystone of lipid lowering therapy is statin, whatever be the lipid abnormality. But in patients with PCOS, the problem is we have a situation where the triglycerides are more. We have a situation where the atherogenic, the dense particles are there. So along with statins, if the triglycerides are more, the next drug that we would now use would be fibrates. And also, we would also, now there is a new drug which has come in, which is the DHA or the pentanoic acid. These are also new drugs that may be tried in future. As per the guidelines now, dyslipidemia, we are only treating with statins at the moment, especially only in situations where there is a very high triglyceride level, more than 500. That is a situation when you would start thinking of adding fibrates. So at the moment, these are the two drugs that we may be using, apart from your lifestyle modification.
Yeah, absolutely. The statins is the cornerstone, and all the others possibly you use only if the situation demands it. Dr. Sinha, we were talking about your approach to the glucose the diabetic status in PCOS women. You have to unmute.
It has been a very enlightening experience for me as well, learning gather that approximately 20% or maybe more of our females are suffering PCOS, and their family members are not immune to the effects of PCOS either.
Dr. Sinha, can you do me us a favor? Can you cut your video, and because your voice is breaking? Yeah.
Okay. You're audible right now?
Better.
Yeah. Thing is this, that coming to the topic at hand, that how do I improve the insulin sensitivity and in a patient, given that the insulin has a centrality in the whole spectrum. About diet, we have been talking a lot about this diet, that diet, or keto diet. The keto diet basically means that you cut on the carbohydrates, take lots of proteins and fat, but this can be sustained over a period of time. Usually the time limit is 30 days, and it does improve the sensitivity in that short period of time. And the other diets, sorry, you can hear me?
Yeah, we can hear you, but then I think now you concentrate on the drug therapy. We have Debabrata to talk about diet also. So you can confine
and
yourself
about
to
the drugs.
yeah.
Okay, thank you. About the drugs that we have in hand that has been used, primarily is metformin, the glitazones, maybe a weight reduction by orlistat, and lastly, we may have semaglutide that is coming on the horizon. All these things that are being used, metformin has been studied widely, but its results has not been consistent. It's supposed to improve the insulin sensitivity in the liver and in the peripheral tissue, but results of the findings have not been consistent. Glutazones have also been shown to be beneficial, but they are generally difficult to handle. They might lead to some cardiac problems or fluid retention, weight gains, and everything. Reducing weight has always been beneficial for PCOS, and to that extent, a combination of orlistat, phentermine has been used outside India. Phentermine, I don't think is available in India, but has been found to be beneficial. And lastly, the first drug that has been recommended these days for weight reduction and improving insulin sensitivity is semaglutide. So these are the armamentarium, but none of these have got a very strong evidence base in improving the insulin sensitivity. But basic things remains the diet, a low glycemic index diet, and exercise works best. Maybe you can add metformin to that.
Okay, thank you. Thank you.
Sir.
Yeah, please go ahead, Dr. Desai.
Sir, we got a very brilliant input from Dr. Madhuri Patil. And she is right in a way. She tells that when statins are being enlisted, statins are still not recommended safe for pregnancy. Now you will ask, how does that come in the picture? A subject with PCOS on which you have had indication for starting statins, whatever way she conceives, maybe at 40, 42 also with master IVF people like Dr. Durusha, she has conceived and she is on statins. Statins have been found to be safe in animal experiments only, so you will have to discontinue because we are looking at statins for prevention of preeclampsia now, currently. So that is a small note which came from a very brilliant person, Dr. Madhuri Patil. That if
Absolutely.
You are,
we have also contraindications in any situation. We never give statin to pregnant women. So we have drugs like ezetimibe.
Yes.
Ezetimibe is now available, and I don't think it is a contraindication to pregnant women. Or at times, if your triglyceride crosses more than 500, or basically the fibrates are used mostly to prevent pancreatitis than coronary artery disease. But we have drugs available. So in these situations, but these are generally we always insist on statin because they are the most research, most useful, beneficial drugs. We do agree, Dr. Madhuri's point. And now the most important thing in PCOS we advise is lifestyle modification. And Debabrata, the importance of diet, exercise in these.
Yes, sir. So in diet and exercise, they are the cornerstone of lifestyle modification and more relevant for those who are overweight. The aim is to lose at least 5 to 10% of the body weight in the first year because it leads to a decrease in metabolically active visceral fat, which in turn decreases the insulin resistance. As already stressed by Dr. Venugopal, you need to do regular exercise 150 minutes per week, which should include at least 90 minutes of moderate intrinsic aerobic activity. Now, coming to the diet, so you have to use carbohydrates with low glycemic index. And especially you have to give importance to dietary fibers because these dietary fibers can decrease cholesterol and slows absorption of carbohydrates, which can improve the insulin resistance status. You can have 30% of your total calorie coming from proteins, because these proteins, they take longer to digest, and this can improve, again, insulin resistance. Fats can form 30% of the total calories, and monounsaturated fatty acids, which can improve cholesterol, glucose levels, and insulin resistance are preferred. And very long chain polyunsaturated fatty acids like omega-3 acids are very important for the diet, because that can decrease the triglycerides and can also decrease the inflammation. And what is also important is a healthy eating pattern. So it is advisable to take small portion of calorie appropriate meals at frequent intervals, rather than to maintain fast and then you go on a binge episode of eating.
Yeah, thank you. So we can never do away with the lifestyle modification, which is the sheet anchor of treating diseases like PCOS. Now, Dr. Majella, now Venu mentioned about the bariatric. Now you have seen where we see a lot of patients who are very keen for bariatric surgery. What about that?
Yes, as rightly mentioned by sir, first is diet and lifestyle modification, along with metformin therapy, all other things to reduce it. So now coming to bariatric surgery, which is a novel technique which was first promoted by Dr. Edward Mason, who's father of bariatric surgery. The current thing is bariatric surgery, whether we have to do it for PCOS women, and what type of surgery will be benefit? These are the two questions to be addressed. So there are different techniques, as already been mentioned. One is the laparoscopic sleeve gastrectomy, laparoscopic adjustable band, gastric band, and the other technique was the Roux-en-Y gastric bypass. And the newer one was, another one was the biliary pancreatic diversion. But when coming to all these four techniques, it was found that this biliary pancreatic diversion, Roux-en-Y bypass graft, gastric bypass graft, and sleeve gastrectomy, they found to be reduce the weight. The weight loss was really very good, and it was found to be very beneficial. It was found to reduce the weight gain in PCOS women. But there were some amount of side effects, which was more with the biliary pancreatic diversion. Whereas the other techniques, the side effects, especially with the sleeve gastrectomy, it was relatively less. Now, coming to the advantages of these bariatric surgeries in PCOS women, it was found definitely to reduce the hirsutism. It was definitely found to reduce the menstrual irregularities. It is definitely found to improve the diabetes status, the insulin resistance. But there are, as of now, only 6 manuscripts and 4 abstracts which comprises the bariatric surgeries in PCOS women. There is yet to have a large randomized control trial to confirm the beneficial effects and to say it authentically. Definitely, it improves the quality of life. Definitely, it improves the patient's well-being as well as the lifetime also. But there is this is the last say from the American Society of Bariatric Surgery and Metabolism. They say that definitely it improves fertility, but concurrent or the fertility status, whether it is found to be persistently found to be beneficial with bariatric surgery, is yet to be confirmed by large randomized control trials. That is the final word which I would like to point out here is, though there are so many numerous benefits, a large randomized control trial is yet to prove that. So
You have a very strong point there. We need to have more data before we advocate bariatric surgery in these women. Now, Shiba, I mean, one of the questions that our society friends always wanted is, when will you want our gynecology friends to send patient to us?
Yeah, surely, sir. Though we would always like to be associated with our gynecologist friends, whatever stage be it. But yes, there might be certain pointers when we have to convince our patient to go and meet the cardiologist. So we discussed about the NHRM guidelines, which we said that we need to look at our patient, measure their blood pressures. So when we start measuring their blood pressures and we find them slightly elevated, so elevated, somewhere between 120 to 128 or 129 and 80 to 89 is a slightly elevated blood pressure. So this is a time where we need to tell our patients that they are becoming pre-hypertensives. And when these blood pressure readings persist, we should insist that they meet the cardiologist and they get their blood pressures controlled. And again, we need to have a look at their sugars, the fasting blood sugars and HbA1cs. And if they are deranged, and especially when I mentioned those risk factors, if a patient has history of gestational diabetes, premature family history, is a current smoker, so impaired glucose tolerance, all these things are present, then they need to be cautioned also, and they should be meeting the cardiologist for their further evaluation. Not to forget is the symptoms of the patient. If the patient comes to you and patient says, I walk and I feel breathless, or when I do more than normal physical activity also, I'm feeling breathless, we need to actually look at this patient, especially if the patient is diabetic, because diabetic patients can have silent events. So they need to have their ECGs done, their electrocardiograms, and if they are pointers, echocardiograms and a stress test also be done in time. And this is especially true because so many PCOS patients, especially when they cross 40 years of age nowadays, as you mentioned, that they want to go in the masterly hands to conceive. So at this point of time, we have seen patients in a very bad shape in their second and third trimesters, especially when they are elderly and they have conceived and they are pregnant. And it's a pity to look at those women. So we should look at these women in time, and when they are planning to conceive and they are having this age of beyond 40 and they are having PCOS, we should do their CAC scoring, look at their calcium scoring in their CT angiograms, and if it's more than 1 and there is evidence of subclinical atherosclerosis, it should be managed in time. So we need to have our gynecologist friends with us throughout, but these pointers should not be missed.
One clinical point here, sir. Sir, please permit me. Very wise input. Entire panel is giving lots of inputs to us and teaching us. Ma'am, when I was 15 years before in my practice, we were seeing, even in the medical college, we were seeing patients who were undernourished, pregnant mothers. Now we are seeing, yes, malnourishment or improper nourishment, yes, but in the higher side, pregnancy starting at 128 kilograms. I am handling such pregnancies these days, therefore we require your help. And we are going to send to you my request to the dynamic president of the association to please spread this message to your members. And we are going to specifically send to cardiologists, because they have to undergo these people have to undergo the stress of delivery. And that is the time your assessment is going to help us a lot, and your support will require much more than anyone else. So thank you very much for brilliant input. Thank you.
We are there to support this society.
Thank you, sir. Yeah, we know it, sir, because still Dr. Venugopal, when you are telling, he has reminded me of God. Whenever you call, Venugopal, are you there? And he appears. So you are like God, sir. Whenever available, ask for, you are available.
Venugopal is Lord Krishna's name.
I know, sir. I know.
Anyway, so we are coming to the fag end of our discussion. We have already crossed an hour. So we can't escape from COVID. And Dr. Madhuri especially wanted to stress the importance of COVID and PCOS. And I was just looking at the data, which showed that one of the largest population-based cohort studies from UK, more than 21,000 women with diagnosis of PCOD, they found out that there is a 52% increase in the risk of COVID infection in PCOD, OS women. And when it was arranged by multivariate analysis, when you adjust it for age, BMI, glucose status, it is still around 28 to 30%. Yeah. So I think, yeah, absolutely. So it tells very well for every one of us to give proper vaccination and tell these women that you are at a heightened proclivity for infection. And Venu, your last question is, what about how much COVID has changed your clinical practice?
My clinical practice, or
I mean, our approach to our
as Dr. Mohan has said,
see, in COVID, I think the most important thing is to prevent the morbidity associated with COVID. And so that the message that we need to give is every patient with PCOS is at a higher risk for morbidities and mortality during COVID infections. Hence, they should all undergo vaccination. It is not to prevent the COVID infection, but to reduce the morbidity and mortality. So this message has to go to every patient with PCOS.
Thank you.
That is very, very important, because you know that they are a subgroup of patients who are at a higher risk compared to the rest of the female population. So I think it's extremely important. The message should go from cardiologists as well as the gynecologists that they should be advised to undertake vaccination. That's my message.
Thank you.
Ma'am, is there anything Dr. Desai wanted to say, or Debabrata, you want to convey something?
We have covered.
Because we are ending the discussion. From my Honorable General Secretary for the Association.
A great learning experience for us. So
Your voice is breaking. Your voice is breaking, Debabrata.
Yeah, am I audible, sir?
Better.
Yes.
Yeah. So it has been a great learning experience. Looking back at PCOS, almost after, at a gap of, I think, 18 years, if not more. But PCOS, the second look at PCOS, it fascinated me. Its intricacies, its pathogenesis, its inflammatory base. And I should extend my sincere thanks to the PCOS Society for taking this initiative for a joint program.
Thank you. Thank you. I mean, I echo the same sentiments, and I can again reassure you as the president of the Cardiological Society that we will definitely want to associate with your society. And if there is any opportunity to propagate these messages on another platform, we are all ready. Thank you, my dear sirs, and thank you, Madhuri, Desai, and Dr. Shah.
Thank you.
Thank you.
Thank you very much, Dr. Mohanan and his team. And I think we had a really great session. And I would also request you to, promote your cardiology society members to become member of a PCOS society, so that the PCOS society members could really benefit from having all of you around. I would now request Dr. Dhurusha to conclude the session.
Yeah, thank you so much, everyone. Thank you so much, everyone, for being with us. And this agenda of collaborating with other societies has been my agenda for this year. We have been collaborating with organizations like the Dietetic Association, the Nutritional Society, the various OBGYN societies, the Psychiatric Society, the Cardiology Society. And now next week, I think on the 9th of October, we are collaborating with the Endocrine Society of India. So intention is to bring all the disciplines which manage PCOS patients together. And as Doctor said earlier, that he's revising it after 18 years. Similarly, we are revising cardiology after God knows how many years. Okay, it may be 40 years for me, but for some other person, it may be 15 years. So the question is, we all need to update our knowledge in every field of where women's health is concerned. And I think it's high time we all collaborate together. And I think we have had a wonderful workshop. I've been glued to the screen and enjoyed every bit of it. So thank you, Dr. Mohanan, for bringing in the Cardiology Society and having us the access to all the updates which we need to do and look after our patients much better. So, and thank you, Pankaj, for this.
Anytime. For you, anytime.
and also all the speakers and panelists, etc. And of course, Madhuri for executing the entire project, whatever we had envisaged to do. So thank you once again, and goodbye to all of you.
Thank you. God bless you.
Thank you. Thank you very much.
Appreciate it. Thank you.